Good evening. I welcome all to our webinar by Nethralaya Uvea Department, Practical Pulse in the Uveitis and Scleritis, a case-based approach. That would be for 1.5 hours. And we have got the privilege and honor to have with us Professor A.V. Ramanan, Professor A.V. Ramanan from Bristol University, UK, and he would be the keynote speaker. I'd like to invite Dr. Sharana Abraham to introduce Professor A.V. Ramanan.
Thank you, sir. We at Nethralaya are privileged to have with us two eminent rheumatologists today to begin our webinar on practical pearls in uveitis and scleritis. As we all know, there is a distinct overlap of ophthalmology and rheumatology specialties in everyday uveitis practice. It is a pleasure to introduce Professor Ramanan. Professor Ramanan is consultant pediatric rheumatologist at the Bristol Royal Hospital for Children and the Royal National Hospital for Rheumatic Diseases in the UK. He is the joint lead for research at the Bristol Royal Hospital for Children and Professor of Pediatric University of Bristol. Professor Ramanan serves as medical advisor for the National Rheumatoid Arthritis Society, Olivia's Vision, and the National Ankylosing Spondylitis Society. He serves as chair for the National Institute for Health Research Clinical Research Network. He is the associate director for the UK Experimental Arthritis Treatment Centre for Children. Professor Ramanan is the recipient of several awards, including the British Society of Rheumatology's Innovation in Clinical Practice Award, the University of Bristol Vice-Chancellor's Health Impact Award, and the Royal College of Physicians NIHR CRM Award for Outstanding Contribution to Research. His research interests, among several others, include biologics for uveitis in children, juvenile dermatomyositis, genetic aspects of JIA, and macrophage activation system. He plays a key role in landmark randomized controlled trials of novel biological drugs, the most important being the Sycamore trial with adalimumab, and also a trial of tocilizumab in anti-TNF refractory JIA-associated uveitis. Professor Ramanan has more than 170 articles published and numerous book chapters to his credit. He is the co-editor of Rheumatology and associate editor for the Archives of Diseases in Childhood. We at the Uvea department at Nethralaya are honored to have had the opportunity to be associated with Professor Ramanan through the years. A very warm welcome, Professor Ramanan. May I request you to please deliver the keynote address.
Thank you very much for the very kind and generous introduction. Just going to try and share my screen if you allow me. Thank you. Can you see my slides?
Yes.
Yeah, thank you very much. So it's an absolute pleasure, and I'm sorry that I can't be there in person, and hopefully in the ensuing months when all of the problems settle, I will once again be able to see you all rather than virtually in flesh. So thank you again for asking me to do this keynote lecture, and it's a pleasure to share this space with my good friend and fellow rheumatologist, Dr. Kaushik. Over the next 25-30 minutes, I'm just going to touch on biologics and novel therapies with focus on uveitis in children with a lot of potential for extrapolation, really. So we'll talk about the therapeutic options, some of the studies which Dr. Abraham kindly alluded in the kind introduction, and then some of the work we're doing to take forward and where the future is. So let's look at the pathophysiology of uveitis. And this is really in pan-uveitis in a mouse model. And so this is more reflective of the pan and idiopathic posterior uveitis you see in adults. But we speculate that in a genetically predisposed host, probably either an infective trigger or microtrauma may lead to this inflammatory cascade. And what we know clearly is that there are a host of cytokines which we can now selectively target. 10 years ago, our treatment of uveitis, both in adults and children, was using drugs which were non-specific immunosuppressive agents, either systemic steroids or methotrexate, cyclosporin, azathioprine, tacrolimus. And now we have drugs which can target the IL-12/23 pathway, such as ustekinumab. We can target IL-17, secukinumab. I'll come back to it. We can target IL-6 with tocilizumab. We can target gamma interferon, although we don't think that's a key cytokine in uveitis. It's a key cytokine in viral response and in the current pandemic, for example, in COVID. And of course, as we all know, we can target TNF alpha, which has been the mainstay of the therapeutic options available currently. So where are we now? We know that these are the therapeutic options available, and then I'll go through some of the biological options. What are the issues with topical corticosteroids? They have limited posterior segment penetration. So if you have posterior uveitis or pan-uveitis, they are really not that appropriate. And then the biggest risk in children is the risk of cataracts. And I'll come back to some evidence for why we believe that. Raised intraocular pressure. And we know that very few children, leave alone adults, are interested in taking more than 2 drops a day. So when you ask them to take hourly drops on the time they're awake or 6 times a day, the compliance with it is a huge issue. And then when we come to anti-metabolites such as methotrexate, mycophenolate, and azathioprine, they work, but they don't work as well as the biologics, and they are not specific in the pathways in the immune system they target. Certainly, steroids remain an option, but systemic steroids in kids has to be really avoided because of the risk of growth suppression and osteopenia. Osteoporosis might be a disease which manifests in the elderly, but its origins firmly lie if you interfere with bone mineralization in the first 16, 18 years of life. Intraocular steroids are really only used in refractory patients because of the significant risk of cataract and raised intraocular pressure. So which brings us into biological therapies, which I'm going to touch on, which I think has really revolutionized rheumatology and is increasingly having an impact in ophthalmology. So whenever children with uveitis or adults with uveitis get cataracts, we always say we can't say what proportion of that cataract is due to the underlying uveitis and what proportion is due to the topical steroid drops. And this nice paper from Jennifer Thorne in Boston shows that in children who have inactive anterior chambers or no active uveitis on topical steroid drops, that if you're on more than 2 drops a day, you have a significantly increased risk of cataract development in the absence of an active inflammatory cellular count on the AC. So this neat retrospective study demonstrates clearly that steroid drops alone will induce cataract, thereby suggesting that we must really avoid the use of topical steroid drops, except in short periods of time. So this is what led us to the paper which we mentioned we published a couple of years ago. What we did was an 18-month randomized, and in rheumatology, we call it double-blind, until my ophthalmology colleagues said it's not a good thing to say double-blind in a uveitis study to a patient. So we call it double-masked, placebo-controlled trial, which was stopped at the end of 90 patients. But our primary objective was to see if adalimumab plus methotrexate was better than methotrexate plus placebo or methotrexate on its own part. And this was an investigator-initiated study. The results of this study have led to the drug being licensed and approved by 78 countries around the world, including by FDA, European Medicines Agency, and multiple other countries. So we took children between the ages of 2 to 18 who had active JIA-associated chronic anterior uveitis. They must have been on methotrexate for at least 3 months, and they shouldn't have changed the dose of methotrexate for the last 4 weeks. And we gave a fixed dose of 20 milligrams if you're less than 30 kilos every 2 weeks, and 40 milligrams if you're more than 30 kilos. And we continued with a placebo. We followed them up for a period of 18 months, unless they had a significant flare, in which case they were unblinded and exited the study. The study was stopped after 90 patients by the Data Safety Monitoring Board because of an overwhelming efficacy. So there were 16 treatment failures in the 60 patients, because this was a 2:1 randomization to make it more palatable for the families participating, that they were going to hopefully get an active drug. So 16 failures in 60 patients on adalimumab compared to 18 failures in the 30 patients in the placebo group, which gives a very significant p-value of less than 0.0001, which is why the study was stopped. It's not enough, as most of you ophthalmologists would know, that if you can control the inflammation, you also want to reduce the drops. And I've just demonstrated to you that 2 drops is the key for the ability to induce cataracts or not. So this survival curve shows we were able to reduce the drops in the group which had adalimumab compared to the group which had placebo. And most of us aim for, although we rarely achieve it, for no cells and no drops. And so this is demonstrating the ability to reduce to 0 drops in the adalimumab group compared to the placebo group. So really demonstrating that adalimumab is effective. And even in the 25 to 30% of placebo patients who had a response probably to sustained methotrexate, it took an incredibly long time. And these are the patients in whom you have active uveitis, either 1+ or 2+, you will have a risk of getting posterior synechiae, band keratopathy, or increased intraocular pressure, or cataracts. So adalimumab works early and is effective in controlling the inflammation and in the ability to wean the steroid drops. But the big question then comes, can you stop the adalimumab? How long do you give these patients adalimumab? So we took a cohort of patients. 1/3 of the patients in this study were recruited in Bristol. So we thought we'll follow the Bristol patients for a long period of time. And we just published this a year ago in American Journal of Ophthalmology. And it's a complex study, but let me tell you that apart from one patient, every other of these 28 patients had a flare needing to restart adalimumab. So we have been very effective in controlling the inflammation, but we have not been very effective in our ability to wean the biologic, which has important socioeconomic or cost issues in that you can't keep treating these children with the biologic for long periods of time. Although we feel with more data that it's relatively safe, we're worried about the implications. So what are the take-home messages from the adalimumab trial? Adalimumab is safe in methotrexate refractory JIA-associated uveitis. There were no new safety signals, so we don't have to worry whether it's safe in children. But 90% of children flare after stopping adalimumab. It might be that in the historical groups we use biologic, and that might be true for most of your practice, we wait for a long time. We give topical steroids for half a year or 1 year or 2 years. Then we start methotrexate. We may try mycophenolate and then go to adalimumab. So maybe we miss the window of opportunity. We certainly know from the world of rheumatoid as well as in angstpond that early intervention might potentially help switch the disease off. Late intervention might control the morbidity, the ocular morbidity in this case from uveitis, but may not help you to immunologically switch the disease, which is why you're needing prolonged courses of a biologic. We also did some cost effectiveness analysis, and this helped. This was prior to adalimumab becoming a biosimilar in the UK. Adalimumab is now a biosimilar, or biosimilars are now available, and the cost has come down by about 80%. And this was one of the few studies, or probably the only one in pediatrics, where we actually did a prospective analysis of number of visits if you're on adalimumab compared to number of visits to the hospital if you're placebo, and calculated the costings, which helped the National Health Service in trying to bring the price down for the biosimilars when they had negotiations with them. So this is a paper we've just published a couple of weeks ago. And what we did was we took all the trials and all the retrospective studies, and we thought we'd look at the, do a meta-analysis of the anti-TNF efficacy in childhood chronic uveitis. So we looked at 688 articles. We rejected 140 because they were duplicated, considered a primary 548 articles, went through those which fulfilled the criteria for doing a systematic analysis. And of those, we identified 14 articles which met all criteria. 12 were in adalimumab. So that's where the greatest amount of evidence base is. Only 3 met the infliximab, the criteria for shortlisting and looking at a systematic review, and 2 were in etanercept. So let's take etanercept. We know etanercept, although it's an anti-TNF, it's a completely different mechanism of action. It does not work in uveitis, and there is probably a strong hypothesis that it might even potentially precipitate uveitis because etanercept works on the P75 soluble receptor, and we think P55 plays a key role in the experimental autoimmune uveitis in a mouse model. That when you flood the system with etanercept, which might be, you might get an upregulation of the P55 TNF receptor, which might lead to new onset uveitis, which is something people have certainly observed in those who start etanercept for angstpond or in rheumatoid. Infliximab works in about 68%. If you take, that's the take-home message from the meta-analysis. So it is effective. One of the reasons we haven't used infliximab is it's a chimeric protein, so you get more anti-drug antibodies. 2, it's an intravenous formulation, which is, at least in the UK context, more expensive because you have to admit them. So people have really gone for adalimumab, where the greatest amount of evidence is there are 2 controlled trials. Ours is the largest one, and that shows an 86% efficacy at least. And I think it's subcutaneous. And so it's really become the standard of care in terms of first-line biologic after failure of disease-modifying drug, either that is methotrexate or mycophenolate or azathioprine. So this meta-analysis really reiterates the message that adalimumab is the anti-TNF of choice, both in adults and children with uveitis. But we know from our studies, as well as our clinical experience, that not every child or adult responds to adalimumab. There is still about 25 to 30% of patients who are refractory to anti-TNF. So what is our agents for those who are refractory? We just published this 6 months ago in Lancet Rheumatology. Why did we take tocilizumab? What's the background pathophysiology? We know that at least in macular edema, there is a significant correlation between the macular thickness and the aqueous humor levels of IL-6. So showing that blocking IL-6 will have an impact on macular thickness. And IL-6 is a pleiotropic cytokine. And in terms of uveitis, we believe there is enough evidence to suggest it might drive uveitis, particularly in patients who have breakdown of the blood retina barrier. And we think there is a strong correlation between macular edema and IL-6 levels. And macular edema, as most of you know, is sight-threatening. So Marina Mosqueda, who is now in Madrid, but spent some time in Bristol, shows these nice pictures of really very significant macular edema, which resolves dramatically with intravenous tocilizumab. In this case, another patient with vasoproliferative tumor secondary to JIA uveitis, dramatic resolution, again with intravenous tocilizumab. So what we did in this study was we took children between the age of 2 to 18. We said you must have failed methotrexate and you must have failed anti-TNF, infliximab or adalimumab. So these are really moderate to severe patients. Most of them are severe patients. They would have been on 1-2 years of methotrexate, at least 6 months, 1 year of an anti-TNF, and some of them have failed 2 anti-TNFs, adalimumab and methotrexate. And this time we went for an open label design, and we used a novel adaptive design with a Bayesian methodology. But in essence, we were giving either a 2 or a 3 weekly injection, subcutaneous injection of tocilizumab. And again, we didn't go for IV tocilizumab. We went for subcut tocilizumab because it was much more easier. And our primary endpoint was after 12 weeks of treatment. And we were looking at a 2-step decrease in the SUN, or the standardized uveitis nomenclature criteria, which most of you are very familiar with. So we recruited a total of 21 patients, and 62% had unilateral uveitis. The mean age was 12, and the reason much of these patients are older within the pediatric age group is they've had uveitis for at least 5 years, as you can see. Predominantly female, as you know, this is a predominantly female condition, JIA uveitis. And because they're older, more of them are about the age of, about the 30 kilo weight mark. So 7 patients had a 2-stage improvement. And I'm demonstrating the 2-stage improvement in these 7 patients. So they started either at 2+, and you see going down to 0.5, 3+ going down to 1+, say 3 or 4+ going down to 0.5. And this is 3+ and 4+ and 2+ on methotrexate and anti-TNF. And it's likely they may have even failed mycophenolate and tried 2 anti-TNF. So these are really very refractory, severe uveitis patients. And then 3 more had a partial response. And this is the problem, the greatest problem, in my opinion, between inter-observer variation in ophthalmology. Because if you are 1+, to get a 2-step improvement, you need to be 0. And if you bring any patient with 0 or 0.5 to 5 different ophthalmologists, you will get 5 different opinions, because all you need to do is see one cell to be categorized as 0.5. So I really think that these 3 patients went from 1+ to actually getting significant improvement. And perhaps had we used things like FLAIR, which we don't use, maybe we would have had a much more significant response. But certainly tocilizumab doesn't work in everybody. There are some patients who enter at 3+, remain at 3+. There are some who enter at 3+ and get worse going down to 4+. So about half of the patients improve, and significant improvement in a very refractory cohort. And another half do not improve. And it would be nice if we had a biomarker which would help us to tell who's going to improve before we start the medication. Tocilizumab has been used now almost for 15 years in adult and pediatric rheumatology. So the safety profile was consistent with what we already know. And there were only minor adverse events, and there were no serious adverse events. So what is the take-home message? 38% of patients, refractory patients who had failed methotrexate and anti-TNF, had a two-step improvement with tocilizumab, and tocilizumab is available in India. And a further 14% had a one-step improvement. So really, I'd say half of the patients who have failed methotrexate and anti-TNF, tocilizumab is a very effective choice. For cystoid macular edema, really with tocilizumab, there was dramatic improvement both in our trial cohort as well as in our clinical experience, as well as in other people's clinical experience. So tocilizumab is an effective option for those with cystoid macular edema or with uveitis, which is refractory or intolerant to adalimumab. And we're doing this study to answer the problem of when do you stop? Do you stop after 12 months of inactive disease? Do you stop after 6 months? Do you stop after 18 months? So Nisha Acharya and I are doing a trial across US and UK. Our first aim is to decide when can we stop. The second is, can we have some biochemical predictors of who's going to flare in advance of stopping? And what we're trying to do is flare is, again, very straightforward. It's an AC based one. We're going to recruit 59 patients in US and 16 US, 16 UK. And these are the sites in US which are recruiting. We are almost 1/3 of the way down in the study. These are the sites in Bristol, and I'm leading it in the UK. So we're going to take children between 2 to 16 who have been stable on adalimumab and who have inactive disease, so at least 0.5 or less, and they are on a regular stable dose, controlled inflammation in the eyes, controlled inflammation in the joints. And we are going to take both, in US, they use adalimumab, Humira originator molecule, and in UK, we're using a biosimilar. So this study will demonstrate that it doesn't matter what you do. And we're going to randomly switch on a 1:1 basis. Either they will continue to get adalimumab or they'll be switched to placebo. And both the participant and the investigator will be masked to who's on the drug and who's on the placebo. And we'll follow them closely for the first 4 months. This is because if you stop, you're more likely to flare by 2 to 4 months' time, and then in 2-monthly intervals. So what does the future look like? And I'm going to touch on the JAK kinase inhibitors, which I think is the next revolution for the decade that's going to come up, 2020 to 2025 at least. The JAKs are going to dominate the world of rheumatology. I was just saying in the preamble, baricitinib is showing antiviral properties, and I'm running a trial of baricitinib globally in COVID. So the JAKs are proving they're oral molecules, they are small molecules. Once they go off patent, they'll be as cheap as paracetamol. And they've got significant effects. They have an impact on hematopoiesis, Th17 differentiation. And if you remember my first slide, the role of IL-12, 23, and IL-6 in the pathogenesis of experimental autoimmune uveitis, as well as gamma interferon. So really, blocking a JAK, whether it's JAK1/2 selective or JAK1 selective or JAK1/2/3 blockade, you may have an impact. And we have a host of other molecules. We're about to start a trial of IL-17, secukinumab, as a head-to-head with adalimumab, hopefully in the second half of 2021. I've got a large grant to start that study. We have IL-12, 23 blockers like ustekinumab, and a host of other molecules, which I won't go into detail unless anyone has any questions. But let me touch on the JAK-STAT pathway. JAKs have a huge role in T-cell proliferation, Treg function. They have a role in response to helminths, airway reactivity, and they're going to be used in certain lung conditions, certainly in an acute phase response, which is where the COVID pathophysiology comes, significant anti-inflammatory and antiviral response is why it's proving to be helpful in adults, and we're going to trial children with primary COVID infection. So the trial we are running currently, we are halfway down this, is to take children who are methotrexate refractory with chronic anterior uveitis, either JIA or idiopathic, and we're going to do 10 of them you will have a 1:1 randomization to either adalimumab or baricitinib. And we'll also take a cohort, which is both anti-TNF and methotrexate refractory, to see if baricitinib can be effective, not just in the methotrexate refractory population, but also in the TNF refractory population. And then we have an extended follow-up period for a couple of years. We're hoping to finish this study by the second half of 2021. So the next time I speak to you, I can give you the baricitinib results, as well as probably some early results from the trial I'm running with Nisha. So to give you a take-home message, even in 2020, at least in our experience, if you have JIA-associated uveitis, you have a 1 in 3 chance of having an ocular uveitis-associated complication. In children with JIA-associated uveitis, it's usually raised intraocular pressure and glaucoma. If you have idiopathic uveitis, more likely to develop macular edema. And probably this is down more to screening and absence of screening. Cataract and posterior synechia are frequent complications, showing that ocular morbidity is still an issue in spite of biologics. And the future really is when you have a patient present to you with chronic anterior uveitis, you want to be able to predict using omics which patient is going to respond to TNF, which patient is going to respond to IL-6 blockade, who's going to respond to JAK blockade. And we are trying to do the stratified medicine approach. We have a large funding from the UK government of 5 million to look at uveitis in children and arthritis in children and stratify them on several endotypes. We've got some amazing data scientists, and hopefully in a couple of years' time, when I come back to speak to you, I can show how we can probably at diagnosis predict who's going to get uveitis, and once they get uveitis, who's going to respond to a TNF, who's going to respond to an IL-6, or who's going to respond to some of the new molecules. With that, I'm going to stop to take questions. I've left a good 5 or 6 minutes for those who want to ask me questions. So thank you very much again for asking me to speak to you virtually. Thank you.
Thank you.
Thank you very much.
Wonderful lecture.
Thank you very much, Professor Ramanan. Our chairperson for today is Dr. Vivi Kaushik, an eminent city rheumatologist. We welcome Dr. Kaushik to the meeting. Dr. Kaushik is a senior rheumatologist at Apollo Hospitals in Chennai. After graduation in 1995, he went to the UK for further training and specialization. After completion of general professional training and working at the Royal Liverpool University Hospitals for completion, he did his completion as specialist training in rheumatology. He was a consultant rheumatologist in the UK until 2012 when he returned to Chennai, where he currently works. We welcome Dr. Kaushik and request him to lead the discussion.
Hello, can you hear me?
Yes.
Yes.
Yeah, sorry. Thank you, Dr. Ramanan. It was a very exciting talk. Now, before we take questions from the panel, I have a few thoughts on these. Number one is, as you clearly pointed out, there is a recurrence of the inflammation once the adalimumab is stopped. Now, this is definitely a problem for us in India, where even at the start of therapy, we need to give them a price point where how long and how many injections we have to use. But saying that, I don't know, my ophthalmology colleagues would be able to shed more light on these. Now, from what I can see, more than 60% of our patients, we give a course of 3 to 6 months, and the relapses, but obviously this is the adult patients I'm talking about, not the JIAs. So they are not relapsing as much once we maintain them on a small molecule DMARD like methotrexate. So that's one point for discussion. And I'll just finish. The second point is, like you rightly pointed out, we do have a generic tofacitinib now in India, and but there has been a generic tofacitinib in Bangladesh for the last year or so, but it doesn't seem to be as efficacious as Xeljanz. So we are a bit skeptical. So we're just trying it out, so we may be able to give you more information the next time we catch up. So I'll leave the adalimumab question up to you.
Yeah, no, that's a very, it's a difficult one, really. So maybe for the Indian context, where people can only afford 3 months of treatment or 6 months of treatment, it would be better to try and use it much earlier rather than later in the disease. So you can get the greatest bang for your buck by using early anti-TNF rather than late anti-TNF. That would be my only message to the ophthalmology community, to not cycle through multiple agents such as methotrexate, cyclosporin, MMF, and perhaps go for a short, sharp course of anti-TNF early and see if that helps switch the disease off.
And what do my, Dr. Biswas, please can you enlighten us on how do you see a short course of adalimumab followed by a IMT? Do you find them efficacious?
I have seen that the adalimumab can control the uveitis, but that long-term treatment is a problem. I find quite effective. Methotrexate is quite effective in controlling the inflammation in our setup. That much of resistance, I don't see that in methotrexate in my hand.
Mm-hmm. Okay, so I'm not sure. I mean, there are a few questions on my. Do I take the questions one at a time? Is that what we do? Do we pose it to Dr. Ramanan?
Yes.
Is that okay? So the first one is from a Shahana Majumdar. Any evidence to suggest that early adalimumab may help in weaning off adalimumab? Perhaps this was answered, but
yeah, no evidence yet. It's just hypothesis.
Okay, so the next question I have is from Shaukat Ali. Is there any head-to-head comparison for anti-TNF alpha inhibitors versus interleukin antagonists in JIA?
No, no head-to-heads yet.
These are very short answers. Come on. Okay, fine.
Yeah, no, I think it's a good question, but it comes back to the next question in a TB endemic area, what biologic would suit. So all biologics, as far as uveitis is concerned, are not equal. I've just demonstrated that etanercept does not work, but etanercept's biggest advantage is it's got the least risk of TB, but it's really not an option in uveitis. So you're left with two options, infliximab or adalimumab. Infliximab being a chimeric protein, you'll have a higher incidence of anti-drug antibodies, what we call as human anti-chimeric antibodies. And it's also intravenous. So really the drug of choice in terms of anti-TNF is adalimumab. And in terms of head-to-head studies, it's been a huge problem because pharma so far hasn't been keen on doing head-to-head studies. If you take rheumatoid arthritis, which is where the greatest amount of evidence is, for the first time, baricitinib did a trial of Bari versus adalimumab, demonstrating baricitinib was better. And in the baricitinib study that I'm doing, we've got a control or a reference arm of adalimumab, and we are hoping with clever statistics, even with a small sample size, to demonstrate that in a biologic naive patient is the baricitinib more effective than in the compared to the biologic, really. But such head-to-head studies have not been forthcoming so far, but the future will have a lot of them because we have biosimilars now. With biosimilars, it becomes much easier for drug companies to do these trials so that they can source the competitor drug at a much cheaper price, which used to be a big problem for anybody who wanted to do a trial involving adalimumab. And I can take a question, Kaushik, which says, how fast does TB adalimumab act in an acute setting? In an acute setting, it depends. If you've got 3 or 4 plus AC, you've got macular edema, I don't think you can just give adalimumab and wait. You've just got to use pulse methylprednisolone or oral prednisolone in that setting. If it's 1 plus or 2 plus, you can see adalimumab and start and wait for some effect. Because most of the patients who present with 1 plus and 2 plus, the more important reason you might be starting biologic is because they've got band keratopathy, or they've got posterior synechiae, and they've got raised intraocular pressure, or they've got posterior subcapsular cataract, and you think they're heading down the wrong way. But it's not a drug which is going to work within a few days.
I have another question in the sense, with my previous discussions with Dr. Partha Pratim Majumdar, I don't know whether he's on the online at the moment. So his, as he's an ophthalmologist, so his view was a small molecule would be better suited to work in the eye. So would baricitinib or tofacitinib be a better option to adalimumab if and when it becomes a bit more widely available?
Yeah, there's only one controlled trial of a small molecule in uveitis, and that they're using a drug called filgotinib, which is also a JAK kinase inhibitor. But they were struggling to recruit to that study. We believe, based on our mouse model of pan and posterior uveitis, that JAK kinase inhibition should work. And I think if you get biosim or small molecules, which are generic versions of tofacitinib starting to become available, and you're happy with it, maybe an institution like Sankara Nethralaya or all of the ophthalmologists can club together and do such a trial, because it will be very cheap if you have a generic version of a small molecule.
I think that, I think from a JIA perspective, it is you find it difficult to make young children swallow tablets. It'd be easier to inject them, I suppose.
No, they have come in syrup formulation as well, the JAK kinase inhibitors.
Okay,
So they've taken care of all steps.
I've got one question.
Sorry. Yes, Dr. Biswas.
Just, I was thinking that whether there is any difference in the action between the scleritis and uveitis with the small molecules.
I don't know of much literature of small molecule use in scleritis. The problem is we are in the JAK kinase trials, as well as I see lots of questions on secukinumab, and I'll come to secukinumab in a second. But if you take the rheumatoid trials and then look to see if those on the JAK inhibitors develop less scleritis or episcleritis, there's a lot of problem with that sort of trials, because they exclude patients when they enter if they have any ocular manifestations, because that's one of the issues with extrapolating randomized controlled trials to routine clinical care, that these patients are not reflective of your normal patients you see in clinic, because if they have any comorbidity, they get excluded from the study. So study populations, and nobody's done trials of JAK inhibition in scleritis or episcleritis. So really, your questions, I don't know the answer, perhaps you might know. But I'll touch on the secukinumab issue. Secukinumab is very interesting. My colleague Andrew Dick has published a paper on the 3 randomized controlled trials of secukinumab done in Behçet's VKH and idiopathic panuveitis in adults. And he didn't show a statistical significance, but there were some issues with the study. The phase 2 of secukinumab was very effective, but the phase 2 was done using intravenous secukinumab. The phase 3 in uveitis was done using subcutaneous. It seems that for some reason, which I don't fully know why, the pan and posterior uveitis adults need a higher concentration of the drug than the rheumatoid or angst-spawn patients. And so intravenous secukinumab gives you much higher IL-17 blockade than the subcutaneous secukinumab. And that's why the phase 2 studies worked, while the phase 3 with subcutaneous doesn't work. So we are about to start a study, as I said, in summer 21, where we're going to have a trial of secukinumab versus adalimumab, but that would be for anterior uveitis. In the data on angst-spawn, when you look at those on secukinumab, some of the unpublished data suggests that those on secukinumab for angst-spawn develop less acute anterior uveitis. So suggesting clearly that secukinumab has a protective role, because if you have ankylosing spondylitis, you have a 25% chance, lifetime risk of developing acute anterior uveitis. And those on secukinumab seem to have a lesser chance of developing uveitis.
If I may add a point to secukinumab. Now, one thing we find, I don't know, you might have found it in your subgroup analysis, we find that secukinumab is not very effective in the Indian population. I mean, this is only purely from a rheumatoid arthritis perspective. Now, is that something you've come across, you've heard of?
No, we use it mainly in our angst-spawns. And for angst-spawns and psoriatic arthritis, we find it very effective in the skin manifestations, reasonably effective with the angst-spawns, maybe not that effective in the psoriatic arthritis, where 12/23 blockade is far better. but we haven't got any ethnic differences so far, to my knowledge.
Okay.
I think
So,
we have audience question, if I can just ask. It's from an ophthalmologist who wants to know if a rheumatologist is not available, can an ophthalmologist administer subcutaneous adalimumab safely? Is that recommended? Or?
Well, it's not for me to say, but let me tell you what's happening in the world of, in UK at least. We had to work very hard to persuade our ophthalmologists to do any prescribing, because most of them were surgical ophthalmologists and they were much happier doing surgery than doing uveitis. But the government recognized this, and about 8 years ago, we brought in a training program called medical ophthalmology. So now we have ophthalmologists who train, first do general medicine and then do 4 years of ophthalmology, but they don't operate. And they manage uveitis, they manage diabetic eye disease, thyroid eye disease. And because they've got 2-3 years of general medicine experience as well, they're very comfortable both prescribing and monitoring. But it's very much an individual level. If the ophthalmologist feels comfortable, I don't see any reason why not. But I can't speak any more than that. So it's really down to the comfort level of the physician involved.
Thank you. There is another question from the audience. If there is any role of TNF-alpha blockers in GPA?
Well, in GPA, I don't see, it's not my area of expertise, but I know IL-6 is thought of as having a role. TNF, I don't know. I don't manage, they're talking of GPA as in granulomatous polyangiitis, which used to be called Wegener's. Then we use more of rituximab and we use more of cyclophosphamide, but there are case series of TNFs, but I'm not sure there are trials of TNF. For GCA, which is giant cell arteritis, which is more ophthalmology related, certainly IL-6 is now a licensed and approved biologic.
Are there any other questions that the panel or the audience would like to ask either Professor Ramanan or Dr. Vivi Kaushik?
So there's another question I can see about MAN2 positive family history of TB. I think if you have got MAN2 positivity, or if you're in, an IGRA, what we call as interferon gamma release assay positive, then people would say you must treat for latent TB, not open TB. I mean, of course, most of you are more aware of TB than I am. But we would treat. Sorry.
You.
No, I said we would treat for latent TB in such settings, but not for open TB unless the chest X-ray shows findings.
I mean, what I was about to say is, although we come from a TB endemic area, we don't see that much of reactivation of latent TB. I mean, basically, we do the screening. I still do only MAN2 because there is lots of the QTG and all that in the endemic area is met with lots of criticism. So if you have a MAN2 strongly positive, then we get the advice of the infectious disease doctors. But the bottom line is, given our course is fairly short, maybe that's one of the reasons why we don't get any major. I mean, I've seen 1 or 2, but that is over thousands of patients we've treated with adalimumab. So if that helps. And I just wanted to do a small clarification. I think what I was meant to talk about was tocilizumab and the Indian population, not secukinumab. I just got the names crossed. I do apologize. We're talking about the rheumatoid arthritis, and tocilizumab doesn't seem to be as effective, not secukinumab. I do apologize.
Yeah, no.
Thank you very much, Professor Ramanan and Dr. Kaushik, for that very interesting discussion. If there are any further questions, we'll probably deal with them at the end of the session. I'll now hand over the session to Drs. Arshi and Neetu for the next part, which is a case discussion. The chairperson will be Dr. Jyotirmay Biswas. Thank you.
So we have got a galaxy of 6 interesting and challenging cases. This will be presented by our Uvea fellows and consultant Dr. Amitabh Kumar, and discussed by our consultant in Uvea department. So let's look at the case. So, Dr. Arshi will be conducting the first three cases. Dr. Arshi, please.
A very good evening to all of you. On behalf of the entire team at the Uveitis department in Sankara Nethralaya, Chennai, I welcome you to the second part of this session today evening. The session, as Dr. Biswas just outlined, will be proceeding as follows. So we have a case presentation being done by one member of our team first, which will be followed by the discussion of the salient points of each case by our senior consultants. And we encourage you to please post your queries in the Q&A box, which you see below at the bottom of your screen. And we can forward these queries to our panelists for discussion. And I hope we all have a very enjoyable and lively discussion for these case presentations. So to begin with, I would like to invite Dr. Divya Thatikonda, who's a fellow in the Uveitis department at SN Chennai, to present her case. Dr. Divya, please.
Good evening, one and all. I'm sharing my screen now.
Dr. Ramanan, thank you for the excellent talk.
Thank you. Thank you very much. I'm still here.
Yeah.
Just...
Is my screen visible, ma'am?
Yes.
Yes, Divya, we can see the screen.
Okay. Good evening, one and all. Today I'm going to present a case. A 28-year-old male, a doctor by profession, presented to us with floaters and diminution of vision in the left eye for past 6 months. There was no history of trauma, fever, or rash preceding the ocular symptoms. He was diagnosed elsewhere as left eye retinal perivasculitis. Before going into the details of that, we'll look into a past history. Since 2001, he had various complaints, including skin rashes, multiple joint pains and swellings, back pain, morning weakness, and stiffness. After extensive investigations by rheumatologists at CMC Vellore, he was diagnosed as HLA-B27 related spondyloarthropathy, inflammatory bowel disease, and psoriasis. His medication history: in the past, he was using infliximab 5 milligrams per kg every 3 to 4 months since 2015 and sulfasalazine 3 grams per day. After the onset of ocular symptoms, he was shifted to infliximab 5 to 6 milligrams per kg every 2 monthly, sulfasalazine 2 grams per day, and tablet prednisolone 20 milligrams, which he had stopped 1 week before presenting to us. He has also used methotrexate in the past, which was stopped due to abnormal liver function test, and he's been using prednisolone on and off. This was the color fundus photo and FFA at the time of presentation, that is in October. With the color fundus photo of the right eye is normal, left eye shows retinal vasculitis with FFA showing leakage. This is the serial fundus photos of the left eye through the course of the disease, showing active vasculitis that has progressed to occlusive vasculopathy in spite of the infliximab and steroid therapy. Why did he consult us? He was a doctor with HLA-B27 related spondyloarthropathy, was having retinal perivasculitis, which was not responding to infliximab and oral steroids, and he wanted to have a second opinion to know the reason for the unresponsiveness, and because the disease was not fitting into the picture of HLA-B27 related uveitis. When he presented to us in March, he had 6/6 vision in both eyes, and his anterior segment was normal, and left eye showed a few anterior vitreous phase cells. This was the right eye was normal on examination. The left eye fundus picture was normal, but FFA showed wedge-shaped capillary non-perfusion areas with active vascular leakage. SSOCT, the left eye showed ellipsoidal layer thinning with hyperreflective echoes and RPE atrophy temporally. In investigations at CMC Vellore, HLA-B27 was positive, HLA-B51 was negative. His serum ACE was within normal limits. A QFT gold test was done prior to initiation of infliximab therapy, which was negative. A recent HRCT thorax and abdomen was done, which showed calcified granulomas in the liver, few small solid nodules in right lung, and small ground glass nodules in left lung, which suggested infective or inflammatory etiology. There was mild pleural thickening with no pleural effusion. There are also enlarged right paratracheal lymph node, which was 11 mm, and subcarinal lymph node of 8 mm with calcification. what was done next? We advised CD4 counts and a repeat quantiferon TB gold test, which turned out to be positive, and his absolute CD4 counts were less than 335. Taking into account these features of quantiferon TB gold turning positive, absolute CD4 count less, and HRCT thorax suggestive of infective or inflammatory pathology, a provisional diagnosis of acquired probable ocular tuberculosis with left eye tubercular retinal vasculitis was made. As the patient was leaving, CMC pulmonologist and rheumatologist opinion was sought. The pulmonologist advised bronchoscopy and bronchoalveolar lavage, which was done in the left lower and upper lobes and the right upper lobe. It showed negative for gene expert also. Rheumatologist advised the patient to stop infliximab, and he was started on antitubercular therapy and prednisolone 60 milligrams. In July 2020, the prophylactic ATT cover ended. Sectoral PRP was done in the capillary non-perfusion areas. His vision was stable and he was not complaining of any floaters. The Bactec MGIT result was found to be negative. Under the rheumatologist care, he was taking golimumab monthly and azathioprine 50 milligrams BD and prednisolone 7.5 milligrams OD. The recent is of November 2020. His vision was stable with no floaters. Thank you.
Thank you, Divya. I would now like to invite Dr. Sudha Ganesh. She's the Deputy Director of the Uveitis Department at SN Chennai. Ma'am, I would like to invite you to please shed light on the intricacies of this case. Thank you.
Thanks, Dr. Ashi. Can you see my slides?
Yes, ma'am.
So,
make full screen.
Is it okay now?
Yeah.
Can you hear me?
Yes.
You'll have to click on the full screen. Yes.
So here, just to sum up this case, this was a young doctor who had a retinal vasculitis, which was not responding to infliximab as well as steroids. And he was already diagnosed to have a HLA-B27 positive ankylosing spondylitis, as well as irritable bowel disease. And the rationale for our diagnosis was that the patient had a clinical picture of IOTB with a primary periphlebitis. He had perivascular exudates and a capillary non-perfusion. His HRCT chest, the recent one in March, showed evidence of an old pulmonary tuberculosis. And the immunological evidence that we had was the patient turned quantiferon positive. So these were some of the positives that made us think of tuberculosis. So we all know that TNF has a role in TB. It's a potent inflammatory cytokine, and it has a very important role in preventing not only mycobacterial infections, but also other bacterial infections. It maintains the immunity in latent TB infections as well as in TB reactivations. And experimental animal studies as well as computational modeling show that TNF alpha is needed for the macrophage activation, apoptosis, chemokine and cytokine production, and the granuloma formation. So what happens when we give an anti-TNF? There may be a depletion of the T cells and neutralization of the TNF or the interferon gamma, as a result of which either a granuloma doesn't form or there is a dissolution of the granuloma, which results in a reactivation and spread of the TB. Of course, these are the anti-TNF drugs that are available, which you all heard from Dr. Ramanan on infliximab, etanercept, adalimumab, golimumab, and the others. These block the TNF-mediated immune responses, and they are linked to TB reactivation. They basically are supposed to interfere with the innate immune responses like the phagolysosomal maturation, monocyte apoptosis, the cell-mediated responses, which include interferon gamma secretion by the memory T cells, and the complement-mediated lysis of MTB-reactive CD8 T cells, and increase in the Treg activity. So we looked into the literature, the Western literature, a study by Wang et al. They did a meta-analysis to investigate infliximab therapy and the incidence of TB infection. 24 randomized clinical trials were included, and the pooled odds ratio of developing TB was significantly higher in infliximab group when compared to placebo. Whereas Dixon et al. Studied the risk of TB in rheumatoid arthritis patients on TNF-alpha therapy, and they found that the patients with non-white ethnicity had a 6-fold increase in risk of TB compared to white patients, and 62% of the cases were extrapulmonary TB. There was a 3-fold or 4-fold higher incidence of TB in those receiving infliximab and adalimumab compared to those receiving etanercept. We also looked at some of the literature from Asia, South Korea, where there's a country with intermediate TB burden. By a study by Jung et al. Showed that there was a higher incidence of tuberculosis in patients, especially with IBD and rheumatoid arthritis, with a higher incidence with infliximab and adalimumab, and significantly lower with etanercept. The literature from India, though not much, there have been about 3 studies. Agarwal et al. Have studied patients on IBD on infliximab. They noted TB despite screening prior to initiation of therapy, and incidence of TB after anti-TNF therapy was significant. 8 out of 69 patients developed pulmonary TB or extrapulmonary TB. Puri et al. Have reported 7 TB cases in 79 patients on infliximab for ulcerative colitis. Krishnan et al. Have reported a case of ankylosing spondylitis who developed pleural TB after infliximab therapy in spite of screening for TB before therapy. So I have some questions for both Dr. Ramanan as well as Dr. Kaushik. The approach to a patient with TB risk factors are different between clinicians in developing countries and those in developed countries. There are clear differences in the clinical preferences, again, between experts who work in high prevalence areas as compared to those in low prevalence areas. WHO estimates 10 million people infected with TB in 2019, and in India, the estimate is around 2.69 million. In endemic countries like India, what are the risks of either a reactivation of TB, a fresh TB, or a latent TB in patients on monoclonal antibody therapy? And what are the ideal screening baseline tests for TB or for viruses like HSV or VZV prior to anti-TNF therapy? And in our particular case, the rheumatologist had switched over to golimumab. Is it safer compared to infliximab and adalimumab? You need to answer our question, sir. Thank you.
I'm happy to go first if while Kaushik's coming. So I'll take the last question first. Golimumab is not any more safer than adalimumab. It's just a long-acting monoclonal anti-TNF. So I don't think you could say that golimumab is safer. And in terms of screening, it depends on the endemic areas. What we do in UK, where parts of UK are endemic, is we do interferon gamma release assay, such as quantiferon gold, which is one method, or there are loads of them, but all of them work on the same principle, which is interferon gamma assay. Chest X-ray, in my opinion, is not that helpful because very few people are going to walk around in our setting with open pulmonary tuberculosis, but might be more helpful. And I think the clue in this case was clearly you have an angstpon patient who's not presenting with ocular manifestations which are reflective of angstpon. So you are sure that you're dealing with something else. Probably the occupation of this patient is also predisposing him to much more exposure to TB by being a physician. And so the risk continues to remain. By being on golimumab is as much as a risk as being on adalimumab. As we've said, the only anti-TNF which has reduced risk of is etanercept, which might be a better agent for this patient for his ankylosing spondylitis. That would be but the problem is maybe it's not that effective for his angstpon, but certainly that would be a better drug in terms of TB risk for his angstpon.
Just following on from Dr. Ramanan, I think maybe there are two issues here. The duration of therapy. There is lots of evidence to say that longer the duration. Am I right or am I wrong? You can, Ramanan, you can help me out on this. Longer the duration.
No, you're right.
There is the more chance of reactivation. So maybe our economic restrictions maybe is in a way helping us. So the short answer to your question is, I personally, in the patients I've seen, have not seen so many TB reactivations. Maybe we are screening better, or the kind of patients I see in Apollo Hospital and in my clinic belong to a slightly different socioeconomic demographic. So it's very difficult for me to comment on India as a whole. But the screening tests I do include a history, a chest X-ray, we do hepatitis screening, and I do a MAN2 test. Now, the quantiferon TB Gold, what happens is sometimes we get a positive test and then it gets poo-pooed by the ID guys saying this is an endemic, it might not work. So, and if I'm not sure, I send them, because given getting an opinion is fairly easy where we work. So I send them off to the infectious disease people. And usually it is either once again, there is lots of controversies regarding this, but most of them prescribe INH only as a co-prescription until the TNF finishes. So once again, there's lots of this, there'll be a lot of discussions around this, and I don't know what Dr. Ramanan will feel.
Yeah, no, the chemoprophylaxis with INH is a good option for latent TB, but if you don't have latent TB, then perhaps that's too much. And there's someone in the chat has helpfully put that etanercept doesn't work in inflammatory bowel disease, and that's absolutely right. And that's why etanercept is also got a lesser risk. So what happens when you give a monoclonal anti-TNF is its ability to break down granuloma. And when you break down a whole yield granuloma, you reactivate TB. And we know inflammatory bowel disease is a granulomatous disease. So that's how it works, a monoclonal anti-TNF. So what makes it work in IBD is what makes a risk of TB. And what makes etanercept safe in TB is what makes it ineffective in IBD. So if this patient's IBD is an issue, which it might be, then golimumab is the right option. If this patient's IBD is inactive and spondyloarthropathy is an issue, then etanercept is a thought. There are no easy answers. They'll have to take the risk between, and INH chemoprophylaxis is also an option, but again, you'll have to talk about hepatotoxicity in the long run and so on. So
I want to ask you that once you start on anti-TNF, how often you will screen for TB?
So it's a very good question. So I think some of the Thoracic Society guidelines is to do it yearly. If you're going to do something, it will probably be worthwhile thing is not to do a chest X-ray, in my opinion, but to do I don't know the value of interferon gamma release assays such as quantiferon gold in your setting. In our setting, they're very valuable. So that can be done on a yearly basis. The advantage of IGRA assays is they are not affected by BCG. So, but in your case, it seems to have been helpful being negative initially and being positive later on to provide you further evidence that this is TB. So in such patients, yearly gamma interferon release assays is what we would do.
Dr. Ramanan, there's another issue in these patients with TNF alpha. Do we need to get do they need to get a VSB vaccine like for shingles?
Well, I think in everybody, it's good to get the Zoster vaccine if they are. So at the time of starting methotrexate, let's assume someone would have tried a much more non-biologic first. They should have ideally done the VZV titers. And if they have had wild type chickenpox, then they're fine. If they haven't had wild type chickenpox, there is good evidence that giving Zoster vaccine alongside methotrexate is relatively safe. And that's what you do, so that by the time you get to starting a biologic in a couple of months or later, you've already got, that's what I would suggest. So whenever you're starting any immunosuppressive, you should check the varicella zoster titers. And if they are non-immune, it might be good while they're on a normal immunosuppressive such as methotrexate or azathioprine. There's good data that it's safe to give the vaccine alongside that.
And does the same hold good for JAK inhibitors as well?
Well, it's very new. JAK data on TB is not good yet because it's mostly used in non-TB endemic areas. So we'll have to wait and see.
What about
until
the
we
vaccine?
have widespread JAK use in India, maybe you might give us more data. It's not being used widely in TB endemic areas. Most of the JAK literature is from Europe and US currently.
What about the varicella vaccine in JAK inhibitors?
No data on that yet. So the issue of varicella vaccine in an immunosuppressed patient is not that the vaccine is dangerous. It's about the seroconversion. So the vaccine, you may not seroconvert. You may not produce a strong enough immune response. It's not that the vaccine is going to be dangerous in itself. So if you are in a situation where you absolutely have to start the biologic or high dose steroids or methotrexate is certainly safe to give with the vaccine, then it's still okay to give the vaccine and give the biologic or high dose steroids. The only problem is you might blunt the immune response to the vaccine, and the vaccine works in any case by stimulating your immune system. And if you blunt your immune system, then you won't have the level of vaccine response you'd expect.
And there is another issue of paradoxical ocular inflammation. You can get a uveitis following anti-TNF medication. How would you differentiate that from an infection?
I haven't seen that. I've seen paradoxical psoriasis with anti-TNF, even though psoriasis is well treated by anti-TNF. I haven't seen paradoxical uveitis, so I would have to say we would struggle, because we had only started. The question is, how would we ever know if it's paradoxical? Because if we had started an anti-TNF for uveitis, then any worsening we'll assume is related to the primary disease. If we have started an anti-TNF for joint disease and then we noted uveitis, then we would assume it's breakthrough uveitis in spite of anti-TNF. So we would rather call it breakthrough in spite of disease rather than paradoxical, in which case we just change the biologic.
Thank you, Doctor.
Dr. Sudha, ma'am,
Yes.
there is a question from Dr. Shivraj Padiyar in the audience. He wanted to know how did you differentiate between the retinal vasculitis due to enteropathic arthritis or ocular TB in this patient? That is his query.
Yeah, that was the same question which I was asking Dr. Ramanan. We were in a fix, we didn't know what to do. So we just went by the IOTB classifications, which have recently published by Dr. Gupta et al., and also the recent article in IJO on TB, as well as looking at the quantiferon, which has converted from negative to positive with positive HRCT findings. So, and the patient was not responding to infliximab and oral steroids. So fortunately, his rheumatologist decided to stop the infliximab, and we decided to give a full course of ATT, not INH alone. We gave him the entire course of ATT for 6 months along with steroids, after which the vasculitis resolved, and we were able to do the PRP once the inflammation resolved. So we assume that it's only a probable ocular tuberculosis. That's how we are putting it as.
I think that's the most appropriate diagnosis, because an enteropathic retinal vasculitis in a well-controlled patient, or who's on an anti-TNF, would be more of a stretch. And you have the immunological evidence, as you pointed out in your presentation. So I think it would be remiss to have not treated for ocular TB in this patient. And why would you, to get breakthrough enteropathic retinal vasculitis on an anti-TNF would be much more an exaggeration of possibilities than a straightforward ocular tuberculosis in someone who has a high risk being a physician, of being perpetually coming in contact with TB.
Yeah.
Thank you, ma'am. Thank you, Dr. Ramanan. Just one last query regarding this case. Dr. Sanjay wants to know if any PCR testing for MTB was done in this patient from our side.
Yeah, PCR of the aqueous we didn't do because the inflammation was primarily a vasculitis. And his vision was 6'5", reasonably very good vision. A doctor who didn't want vitreous biopsy would have been too much. So when I told him the facts, and this case was entirely managed during the lockdown. So he decided to get his bronchoalveolar lavage instead of going through a vit biopsy. So he spoke to his pulmonologist in CMC and he got his bronchial alveolar lavage and other tests. Of course, those turned out negative. Even the backtech was negative. But still, we decided to go ahead with the ATT based on the immunological evidence and the HRCT findings. But maybe, yeah, if the patient had a granulomatous uveitis or there was some reason to take an aqueous or vitreous sample, an RT-PCR would have been the best bet to get an answer.
Thank you so much, ma'am. Moving on to the second case presentation, I would like to invite Dr. Reena, who's a fellow in the uveitis department at SN Chennai, to please proceed with her case. Dr. Reena.
Good evening, everyone. I'll be presenting a case of choroidal nodule. A 66-year-old male from Chennai presented to us with a complaint of diminution of vision in the left eye for a duration of 2 weeks. On examination, we found 3 choroidal nodules, yellowish colored retinochoroidal mass in the left eye, which was inferior-temporal to the disc. And on presentation, his vision was 6/6 and 6 on the right, and 6/18 and 10 on the left eye. Seeing the choroidal picture and the history, we made the differential diagnosis of sarcoidosis, tuberculosis of the eye, and metastasis to the eye. On investigation, we did a PET-CT scan of the chest. We showed 2 non-calcific nodules in the middle and the lower lobe, right lower lobe, and this showed increased metabolic activity, which was suspicious for lung metastasis. Metabolically active multiple nodes were also seen in the paratracheal, subcarinal, bilateral hilar, and para-aortic region, which was again suspicious for inflammatory nodes. On further investigation, we did a bronchial brush and it was negative for malignant cells. HPE of the lymph node showed granulomatous etiology. MRI brain was normal. And on OCT, there was a serious elevation of the neurosensory retina. Further investigations revealed that the blood routine investigations were normal. The ASR was slightly raised, and serum AC level was raised at 81. However, Montux and quantiferon TB gold tests were negative, ruling out tuberculosis. Ultrasound of the left eye showed a retinochoroidal mass that was well defined, and it had a moderate surface and internal reflectivity, which was the dimensions were radially 3.2 millimeter, circumferentially it was 2.6 millimeter, maximum height was 1.2 millimeter, and the retina was attached elsewhere. The rest of the choroid was normal, and scleral shadow was intact with no obvious extraocular extension of the lesion. On FFA, there was hypofluorescence in the early and mid phase and hyperfluorescence in the late phase, which was corresponding to the site of the lesion on the fundus photograph. The provisional diagnosis of sarcoidosis was made, and the patient was started on oral prednisolone 1 milligram per kg body weight. And on follow-up ultrasound, we showed see that there was flattening of the choroidal nodule, and by 4 weeks there was a decrease in the size of the choroidal nodule, and by 3 months the patient has regained his 6/6 vision in the left eye. The patient was followed up regularly at intervals of 3 months initially, and then every 6 months. He was put on tablet prednisolone 2.5 milligram once daily, and then at last checkup, that is after 7 years after presentation, his vision was 6/6 in both the eye. So far, there is no reactivation on fundus examination till now. Thank you.
Thank you, Dr. Reena. I would like to invite upon Dr. Amala George. Senior Consultant at the Uveitis Department, SN Chennai, to please take us through the finer points of this case.
Thank you, Arshi. Yeah, I'll just share my screen. Yeah. Yes, can you see my screen?
Yes.
Yes, ma'am.
Okay. This is a straightforward case, and I thought we'll just discuss how to investigate choroidal nodules like this. Clinically, choroidal nodules are ill-defined. They have a deep yellow and orange hue. The margins are very ill-defined, and they overlie the choroidal lobules. The lesions that you see in white dot syndromes, like APMPP, also are ill-defined and yellowish, but because of the edema in the overlying retinal pigment epithelium, they're more well-defined than a choroidal nodule. They're smaller and far more grouped, and can be easily differentiated with FFA and OCT findings. And retinochoroiditis and retinitis also look very different and far more superficial than your choroiditis. The possible etiologies vary with geographic location, and in our country, tuberculosis and sarcoidosis are the most common differential. Depending on the individual situation, we have to keep in mind masquerades, especially non-Hodgkin's lymphomas and metastasis. So the workup needs to take clues from the history, the age of the patient, what their systemic complaints are. Then lab investigations like we did both for tuberculosis and for non-infectious conditions like sarcoidosis can help differentiate, can help narrow down the diagnosis. Evaluation by the physicians and systemic investigations, again, will provide sites probably for biopsies and a more definitive etiology. Now, again, in this case, we didn't need to do an aqueous paracentesis because it was a deep choroidal nodule. But in patients with more of a granulomatous panuveitis or anterior segment involvement, aqueous paracentesis and sometimes vitreous taps can also help. Ideally, of course, if there is a systemic component, biopsy from a systemic focus would be the best option. Monitoring the nodule, assessing the size of the nodule. If it's larger nodules, then monitoring it with the ultrasound is important. And with smaller nodules, multimodal imaging, both with fundus photography, FFA or ICG, and OCTs, can help monitor the response to treatment. The sensitivity of PET CT scans in detecting active sarcoidosis is close to 80 to 100% and far more than serum biomarkers like serum ACE or lysozyme. And PET scans can help to detect lesions even in people for whom routine investigations don't show the lesions. They can help identify accessible biopsy sites. They quantify levels of disease activity, prognosticates patient outcome, and they can help assess the response to treatment. Now, with sarcoidosis, corticosteroids are the mainstay of treatment. Standard steroid-sparing immunosuppressives are also equally effective. Biologics have been used in selected situations, and I would like to ask both Dr. Ramanan and Dr. Kaushik how often you use biologics for the treatment of patients, even systemic patients with sarcoidosis. And so just to summarize, after we establish etiology, then we need to also document the extent of the lesion to monitor the response of treatment and assess systemic involvement and coordinate treatment with the physician if required. Now, and of course, long-term follow-up, because recurrences are known. It will not happen with our patient, but it's important that they're counseled. Thank you.
Thank you, ma'am. Ma'am, there are a few queries from the audience. One is regarding the utility of a PET scan over HRCT. They want to know when do we prefer to do a PET-CT over an HRCT chest? Is it only because it is a case of a choroidal nodule, or is there any particular indication for doing that in this patient?
I think in this patient, because of the potential for the choroidal nodule, because of the differential of a lymphoma, we went for a PET scan. And also it gives you help with accessing a site for a biopsy. The choroid is a very difficult area to get a biopsy from. And a PET scan will help show metabolic activity. So it's far more useful and helps patients from the systemic point of view.
So we could also say that it is because of probably to rule out a masquerade. So we prefer PET, when we suspect a masquerade, we can go ahead with a PET-CT rather than an HRCT to identify metabolically active sites.
With older patients, especially.
Older patients. Ma'am, there's one more question from Dr. PKP. That how long was this patient given oral steroids?
For about 6 months to a year, till the end of the year. This was Dr. JP's patient. So this patient received the maintenance dose of oral steroids till the end of the year. Yes. So for about 1 year in total, I think, 2.5 milligrams at the very end.
So we did the treatment not only for the ophthalmic conditions. I was thinking that probably a hidden sarcoid, a systemic sarcoid was there. Why the patient at the 66 years age presented with the nodules? So our first thing, we wanted to rule out a metastasis or a kind of a metastasis was the first possibility. And then endemic country, we thought that it could be tuberculosis. But it all came to be negative, and then we go ahead for the steroid therapy and responded beautifully. We continued the steroid for about 1 year in a low reduced dosage, and patient didn't have any recurrence.
Thank you, sir. Ma'am, there is one more question from Dr. Abhishek Gupta. He wants to know whether Manto and quantiferon TB Gold test should both be advised together, or is only one test sufficient?
If it's available, yes, I would suggest that you get the baseline values done, both for Manto and quantiferon, because once we put the patients on systemic steroids, sometimes it's very difficult to know if you're, especially with a Manto, whether it will be accurate. Quantiferon is not as affected by systemic steroids, but there have been reports of quantiferon turning positive if we do it very much after the Manto test. So if you're going to do it, probably do it both at the same time, if it's available, of course, and definitely the Manto test.
Thank you, ma'am. I think there are no more questions regarding this case. So I would like to move on to the third case. I would like to please invite Dr. Adwaita Nag. She's a Vitreoretina Fellow at SN Chennai. Adwaita, could you please present your case?
Yes, ma'am. Are my slides visible?
Yes. Full screen.
Very good evening, everyone. So I'll be presenting an interesting case. Now, the topic beat the heat may seem a little ironic in the middle of winter, but I hope to clear things up by the end of my presentation. So our patient was a 33-year-old male patient presenting with gradual painless loss of vision in both his eyes over the last 1 month. There was no significant history except for that of fever 2 months ago. On examination, his right eye vision was 2/60 and the left eye BCVA was 6/18. Intraocular pressures and anterior segment were within normal limits. Coming to the posterior segment, this was how the fundus looked at presentation. So the first thing that jumps out are these large, fluffy, cotton wool-like white patches in the retina of both the eyes. Along with that, we can see that there's diffuse exudation in both his eyes. If you look at the discs are definitely hyperemic. There is a definite NVD in the right eye, along with some NVE in the left eye, and some specks of hemorrhage in both the eyes. If you take a look at the larger picture, the periphery is mostly unaffected on the montage. So now we went ahead and ordered a few investigations, namely FFA, OCT, Aquastab was sent for PCR for the common viruses like chikungunya, CMV, HSV, and VZV. Serology was also sent for syphilis, toxo, and HIV. These are the FFA pictures. Now taking a look at the early FFA phases, we can see that the areas with the white retinal patches show some hypofluorescence. This is much better seen in the left eye. Along with the hypofluorescent patches, we can see that there is surrounding hyperfluorescence due to vascular staining, vessel wall staining in the adjacent vessels. The NVE and the NVD are also beautifully seen. In the late phases, we can see that there is diffuse leakage in both the eyes, both from the adjacent vessels as well as from the new vessels. Coming to the swept source OCT, both the eyes, we can see that there are numerous hyperreflective foci in the vitreous as well as in the intraretinal layers. These foci are basically suggestive of inflammation. Taking a look at the foveal contour, it's maintained in the right eye with a small bump subfoveally. The left eye, however, shows gross macular edema with large cystic spaces. In the areas with the retinal patches, we can see that the inner retinal layers are hyper-reflective and thickened with backshadowing in both the eyes. This is indicative of retinitis. Moving on to serology, all the serology came back to be negative. The PCR for the viruses was also negative. We now reached a diagnosis of post-fever retinitis. The patient was started on oral steroids 1 mg per kg body weight and he was kept on close follow-up. 2 months after starting steroids, this was how the eyes looked. The retinitis patches have more or less resolved in the right eye, but vision has not improved. But there is still significant inflammation in the left eye and persistent exudation. The patient was now supplemented with oral valacyclovir 1 gram TDS. 1 month after starting valacyclovir, the right eye vision has now improved. But the left eye, there is still a lot of exudation. We can see there are some regressing neovessels with developing fibrosis and some bleeding. He was now given a left eye intravitreal ganciclovir 2000 international units. 1 month later, we can see that there's a dramatic change. Both the eyes have now, the inflammation has now subsided and they look more or less quiet with trace exudates at the macula. Vision is 618 in the right eye and 624 in the left eye. A similar picture is seen at 6 months and also at the 1 year follow-up. And vision, as we can see, has not improved any further. So let's try to find out the reason for non-improvement of vision. These are the serial OCTs of the right eye. We can see that inflammation has decreased as perceived by the decrease in the number of hyperreflective foci. But if we look at the fovea, there is gross foveal thinning and some ellipsoid layer defect. And this is why the right eye vision has not increased. Coming to the left eye, although the macular edema has decreased, the patient has now developed a thick ERM with flattening of the foveal contour. So both the eyes basically developed complications as a result of the retinitis. The left eye underwent surgery, vitrectomy with ERM removal was done. The vitreous aspirate was sent for microbiology as well as PCR, but they were again negative. These are the pre-op and the post-op pictures after ERM removal. The vision in the left eye improved to 6/9 N6 after ERM removal, and at 15 months, this vision was maintained in both the eyes and the fundus was also quiet. With this, we come to the end of our case, and I hope by now we all know how we can tackle a case of post-fever retinitis and therefore beat the heat. I thank you all for giving me a patient hearing.
Thank you, Advaita. I would now like to call upon Dr. Suchitra Pradeep, Senior Consultant at Uveitis Department, SN Chennai, to please guide the discussion of this case, ma'am.
Good evening, one and all. This was the case which we went through very beautifully now. It's a case of post-fever retinitis. It's a young male who had history of fever 2 months before, and after 1 month he started developing the ocular signs, and until otherwise proved, it is a case of post-fever retinitis. Once we diagnose it's a case of post-fever retinitis. I'm sorry, 1 second. We need to go back to the history of the patient, and also we need to note the contemporary epidemics in the endemic area prevailing. We need to ask the history of travel to endemic areas, mosquito bite, stick bite, mite bite, or history of arthralgia, which can lead us to the etiology of the case. So what are all the possible causes? There are, this is a large list of etiology. The left column shows the most common etiological agents, and the right column shows the differential diagnosis which we need to rule out in case of fundus picture like this, where you see the cotton wool spots and other features what Dr. Advaita showed. So what workup do we do? Again, we have a big list of investigations to be done, but we need to understand each and every test cannot be done in all the patients. One, because we need to have the availability of the test in our practicing area, and the patient should be able to afford the investigations. These are pretty costly also. And of course, there are issues with the diagnostic difficulties due to cross reaction between the various etiological agents. Attempts to isolate organism. In various studies, they have failed to isolate the organism, as we did in our case also. We couldn't really find out which was the causative agent for the retinitis. So the next question is whether we need to observe the case or should we treat it? Because there are various studies again addressing this issue. Like there are studies where they have observed and they have seen the improvement due to the natural resolution. And there are studies where they have studied various agents mentioned in the box, like systemic steroids alone, along with antibiotics, only antibiotics. There are various permutation combination of these studies. And finally, the recent study by Dr. Padma Malini, they have concluded that systemic steroids or steroids in any form might not really help in the treatment of post-fever retinitis. They do recommend the use of systemic antibiotics, oral doxycycline or ciprofloxacin. And systemic antivirals, again, we do not have a consensus on using this, but in our case, we started systemic antiviral medications after we gave him a course of oral steroids and he was not responding. Once we started systemic antiviral medications, we started noticing the improvement, and further we gave intravitreal ganciclovir also to supplement, and the lesions resolved. But in our case, we cannot really say whether the systemic antivirals helped in the resolution of the symptom signs, or it was a natural course of resolution. And there are recent reports on anti-VEGF injections in these cases, where they have done the studies giving the bevacizumab injection, and they note, because most of these cases are associated with macular edema, as we have seen in our case also. And giving this anti-VEGF injections are safe and easy, and they do help in the resolution of macular edema. There will be increased VEGF secretion due to inflammation, which will be taken care by these injections. So the main causes of non-improvement of vision in these cases is optic atrophy or ischemic macula. Other complications like macular edema, epiretinal membrane in our case, vitreous hemorrhage due to neovascularization, these can be taken care medically or surgically. So to conclude, the post-fever retinitis is usually a bilateral disease with symmetrical retinitis picture in both the eye. 73% is known to be bilateral. It has widespread in the community, and it has seasonal variations more common during the winter. It has an acute onset, and we saw the diverse etiological causes. It has a favorable response to steroids and antibiotics, and usually it is non-recurrent and has good visual outcomes. But we do not have any large randomized studies on this, which is the need of the hour. Thank you.
Thank you so much, ma'am. Most of the queries which came in between were already covered in your presentation, so thank you for that. Any comments from the panel, from Sir, JP Sir?
I just want to tell you that it's often very difficult to pinpoint a single etiology unless there is a laboratory evidence like typhoid, rickettsia, dengue, etc. But these pictures is more or less is a similar out. The ultimate picture is that some exudates hemorrhage and with edema, retinal edema, macular edema. They do respond to the steroid because it's a not direct infection, it's an immunogenic mechanism which is involved. In our case, they did not respond to the steroid, and we thought that this antiviral drugs was given in this case. But whether it's a natural course or because it didn't look like typical viral retinitis. Viral retinitis is a necrotizing retinitis involving the retinal layer. And we don't see that much of exudates in case of viral retinitis. So this is it's a question, it's a very challenging case.
I would like to add one more point what Sir told. As Dr. Advaita showed, OCT shows inner retinal layer involvement in most of this post-fever retinitis cases. If we see in non-necrotizing herpes viral retinitis or toxoplasma retinitis, it will be full thickness involvement of the retina. That is one of the important clue for us to differentiate between these entities and other retinitis entities.
Thank you, ma'am. Ma'am, there are a few more questions now coming in. Dr. Sonali Khanna wants to know how long the antiviral treatment was given for.
See, usually we give it till the lesions resolve. We do not see any other retinitis patches on the retina. We give the antivirals and gradually we start tapering later.
Thank you, ma'am. There is another question regarding the severe NBD and NBE. This has been posted by Dr. Deepak Dodamani. He wants to know whether there was any significant CNP area noted on a possible FFA if it was done. What was the cause of the NBD and NBE?
See, NVD and NBE can happen because of upregulation of vascular endothelial growth factor, and usually we do not see the peripheral non-perfusion areas in these cases as compared to other occlusive disorders.
Thank you, ma'am. Thank you. Before we proceed to the next part of the discussion, I wanted to come back to Dr. Ramanan, if Sir is around.
Yeah, I'm around.
Sir, I just wanted to go back to the second case, the case of the sarcoid nodule. Dr. Amla had a query regarding the use of possible use of anti-TNF alpha inhibitors. Could you please
Sure. No, I mean, it was a very good case, and choroidal lesions are always, particularly with multifocal choroiditis, you always worry about sarcoid and TB, and that case beautifully excluded TB. We tend to use methotrexate initially a lot to reduce the load of steroids, and we found that to be very effective. And anti-TNFs do work, but in a lot of patients, you can avoid the need for that by just using methotrexate or mycophenolate, which works for the systemic manifestations of sarcoid as well as the ocular manifestations of sarcoid.
So you don't really need the the biologics as much in sarcoid compared to other diseases, right?
No, not. There's two types of sarcoid. As you know, the patient you had was the classic adult sarcoid, and then we have a version which is very ocularly damaging called the Blau syndrome, which is the which I think Sudarshan has a case or had a couple of cases. So there, even with biologics, almost all of our Blaus, we have about 20, have very poor visual outcomes by the time they are in their 20s. And they will sometimes present with just, they'll present with arthritis and uveitis. The rash will not be that obvious, but it's the uveitis over time which will give the very poor outcomes. And there we use biologics without fail, and almost everybody yet don't do well. For the classic sarcoid, we start off with methotrexate or mycophenolate, and depends on sometimes the use of anti-TNF is dictated by the systemic manifestations as much as by the ocular manifestations. But the adult ocular sarcoid usually responds well, like your case, to just steroids and or methotrexate.
Thank you.
Neetu?
Am I audible? Dr. Ramanan, sir, there is another question from you for the audience from Dr. Ranju, who wants to know whether how to proceed with the tapering of these doses of the oral steroids, whether it should be lowered in 2 weekly time or it can be reduced weekly. I'm not sure whether she's referring to the case of the sarcoid. She's not really specified.
It's a very difficult question unless it's got to be individualized to each patient, depending on the level of inflammation in the eye, depending on what condition you're treating. It's very hard to have a set pattern. If steroids is monotherapy, you may want to be a bit more slower. If steroids is, if you're at the same time as starting steroids, you're starting another agent such as methotrexate, then perhaps you can wean the steroids more rapidly. So a lot depends on the level of inflammation, whether it's retinitis, whether it's uveitis, whether it's a choroidal lesion, and what else is there in the background. So I don't think I can give a simple answer which would suit all conditions, sadly.
Thank you, sir. And now to proceed to the next part of the session, I would like to invite Dr. Neetu, my colleague, to please take over moderating this session. Thank you.
Thank you, Dr. Rashi. A very good evening to one and all. I think I'm audible. Sir, am I audible?
Yes.
Okay.
Yes.
So we'll move on to the next case presentation. I would like to invite Dr. Richa, Uvea Fellow from Shankar Nethralaya, Chennai, to proceed with her case. Dr. Richa, you can start sharing your screen.
Thank you, ma'am. I'm just going to be sharing my screen now. Is my screen, are my slides visible?
Yes.
So I'm assuming I'm audible as well. So I'll just begin. This is a very interesting case. The patient first presented to us in March of 2015. He was a 30-year-old gentleman. At this point, he gave history of pain, redness, and watering in the left eye. There's history of trauma to the left eye 3.5 months back. And on examination, the patient denied perception of light in the left eye. IOP was 3, anterior chamber cells and flare were present, and a total cataract was there, which precluded view of the fundus. At this point, the right eye was completely normal. Because the fundus was could not be visualized, ultrasound was checked. It was done outside and showed a total RD. Now, at this point, we basically explained a nil visual prognosis to the patient for the left eye, prescribed protective glasses, and he went back to his native place. The second presentation was 3 years later, and this time he came to us with symptoms in the right eye. Vision had dropped from 6.6 to 6.36. There was a granulomatous reaction, KPs on the cornea, broad posterior synechiae, cells and flare in the anterior chamber, as well as in the anterior vitreous space. He had undergone enucleation for the left eye as it had become a painful blind eye. On fundus examination, we have an optos image which shows hyperemic disc, retinal hemorrhages, and a pocket of SRFs, suggesting an exudative retinal detachment. SSOCT was done, which showed hyperreflective dots in the vitreous cavity, intraretinal hyperreflective dots were seen, cystoid macular edema, and subretinal fluid was seen. In view of suspicion of granulomatous uveitis and the presence of exudative retinal detachment, along with the history of trauma, a working diagnosis of sympathetic ophthalmia was kept. At the same time, based on the OCT findings and the clinical picture, differential of Behçet's was considered. At this point, we revisited the history. The patient now admitted to a history of recurrent aphthous ulcers. Although no other systemic symptoms or signs were noticed after evaluation by a physician. We started him on IVMP 1 gram given for 3 days, followed by oral steroids. Azathioprine and cyclosporin was also added. Following this treatment, inflammation decreased and the patient gained 1 line in visual acuity. He was asked to follow up monthly. On follow-up, a slow oral steroid taper was done along with azathioprine and cyclosporin. Vision improved up to 618. Uveitis subsided. The patient went back to his native place and was followed up locally. He came back to us after 4 months. After 4 months, the SSOCT showed decrease in the hyperreflected dots in the vitreous. The CME had reduced. His subfoveal choroidal thickness had reduced. At this point, he was maintaining on 10 milligrams of prednisolone. Azathioprine was continuing at 50 milligrams once a day. He was asked to review back in 3 months. However, the patient presented to us much earlier. 1 month later, he came to us with a significant drop in vision from 618 to hand movement close to face. A membrane had formed on the anterior lens capsule along with posterior subcapsular cataract. Broad synechiae precluded the view of the retina beyond the posterior pole. An optos image had to be obtained to assess the fundus. This is the optos image. It showed multiple yellow choroidal lesions suggestive of either Dallen-Fuchs nodules or retinal infiltrates. There was disc hyperemia as well, which was not very well visualized in this particular image. On SSOCT, the vitreous cavity was clear. Subretinal fluid was present. We could not image the yellow lesions, however. Fundus fluorescein angiography was done, which showed ferning pattern suggestive of capillaropathy, confirming active inflammation. We again hiked up the oral steroids. IMT, immunomodulatory therapy, was increased. Following this treatment, the inflammation decreased again. The patient gained some vision. He was asked to follow up monthly after this. At this point, a rheumatologist's opinion was also sought. HLA B551 was advised, biologics were advised. However, the patient had financial constraints and could not comply with this. The patient was then closely monitored. He was followed up over 1 year and exacerbations were managed with systemic steroids and azathioprine. Vision was maintained at 618. And then lockdown. So at this point, the patient was lost to follow-up for almost a year. When he came back to us, this is the final presentation. Final vision was 3/60. Fundus showed multiple sclerosed vessels, optic atrophy, multiple punctate atrophic retinal infiltrates. It was a burnt out picture. At this point, we are working with the diagnosis of either Behçet's or with a differential of sympathetic ophthalmia. The questions for our panel: is it Behçet's? Is it sympathetic ophthalmia? Could we have done anything differently? What more can we do for such a patient who is rapidly losing vision in his only eye? Thank you.
Thank you, Dr. Richa. Now I would like to invite Dr. Vinita Girish Rao, Senior Consultant in Uvea from Shankar Nethralaya, Chennai, for the discussion. Ma'am, kindly take forward the discussion, please.
Thank you, Dr. Neetu. Good evening, everyone. At the initial presentation in this case, it could appear to be sympathetic ophthalmia because of the suspicion of granulomatous uveitis. And also the presence of exudative retinal detachment in the right eye. Also, the patient had some yellowish nodules in the retina, which at that point looked like Dallen-Fuchs nodules. And of course, the patient had a history of injury to the left eye, and the right eye was affected almost 3 years after the left eye. So this, at that point of time, this looked like sympathetic ophthalmia. But on the other hand, if you see that during the active inflammation stage, the patient did have occlusive hemorrhagic vasculitis, and the yellowish lesion were more likely retinal infiltrates. And as the patient, towards the later part of the disease, the patient developed optic atrophy, and multiple sclerosed vessels were seen in this patient. So at this, which was favoring more of Behçet's disease. The fluorescein angiography had a lot of capillary leaks, very often described in Behçet's disease. And OCT also showed intraretinal hyperreflective dots, And more significantly, there was no evidence of choroidal involvement. And also the recurrent aphthous ulcers, which is one of the diagnostic features of Behçet's disease. If you look at sympathetic ophthalmia, the fluorescent angiography picture is very different. There are hyperfluorescent multifocal leaks at the level of the RPE, or it can be like an early hypofluorescent or a late hyperfluorescence foci. If you look at the OCT, the retinal detachment in sympathetic ophthalmia has got hyperreflective septa separating it. Also, the choroidal picture in sympathetic ophthalmia will be a little bit more of choroidal involvement, like choroidal thickening or loss of the vasculature, or even demonstration of the choroidal of the Dallenfuchs nodules, which is seen in sympathetic ophthalmia. If you look at the literature study, we have one of the largest series of Behçet's disease is seen from Turkey, and it is published by Ilknur Tutkun, who has also shown that even in their series, almost 20% of their cases are unilateral, which means that you can have an asymmetric presentation of Behçet's disease. They have also shown retinal vasculitis and retinal infiltrates as one of the commonest presenting features. Unlike the hypopyon uveitis, which was shown previously. And FFA, they also say that FFA shows the fern-like and diffuse capillary leakage in many Behçet's patients, and also leakage from large and small retinal vessels, staining of the optic disc. And in OCT, there is focal retinal hyperreflectivity, disruption of the inner retinal layers with shadowing. And also they have mentioned the localized inflammatory vitreous condensation, which they describe as smoking volcano appearance. The other thing which they have said is that with the increased use of OCT, there is more demonstration of, we are able to pick up the exudative retinal detachment and cystron macular edema more often in Behçet's disease. So the prognosis in these patients have always been quite dismal in many Behçet's disease patients. And in the Mediterranean studies have shown that the risk factor is mostly in males who present with earlier onset of the disease and a more aggressive form of the disease. So to answer Richa's question, yes, we should have a close follow-up. We should have had a closer follow-up, but considering the circumstances, it was difficult. If we had a closer follow-up, we would have been able to pick up recurrence in him earlier, and we could have started aggressive treatment. The Mediterranean studies also have shown that we can maintain a lot of patients on steroids, cyclosporin, azathioprine, but biologics probably are much better in these patients. But because of the financial constraints, like Professor Ramanan said, that probably generic drug or cheaper molecules of this will be more useful for our patients who are not able to afford biologics. Thank you.
Thank you, ma'am.
Just want to add one thing. Yes. There is a vasculitis has been described in sympathetic ophthalmia also. I have reported one case of frosted branchitis in sympathetic ophthalmia. Known case, histopathologically proven. But the other things was not fitting with the sympathetic ophthalmia, the retinal involvement, retinal infiltrate. Yeah. One could have done to go to the biologics in this case, and probably the other eye histopathology could have been shown that features suggestive of sympathetic ophthalmia.
The patient was referred for biologics, but unfortunately he was not able to afford it. So we stuck with azathioprine and steroids and cyclosporin.
Ma'am, I think there is not much of questions from the audience. We'll move on to the next case. I would like to invite Dr. Amitabh Kumar, consultant in Uvea from Shankar Nethralaya, Kolkata, for the case.
Any comments from the panelists on this case? The case presented.
I'd like to ask Dr. Ramanan, what would be the ideal biologic in a Behçet's? Is there any?
Yeah, two things. One is possibly you could have used a slightly higher dose of azathioprine because yeah, I think assuming this gentleman's about 50 kilos, you start with 50 once a day. People will go sometimes up to 2 or 3 per kilo. So you could try 50 BD. And although the role of mycophenolate is variable in the non-ocular manifestations, ocular manifestations, mycophenolate is another option. Or tacrolimus. If you can't afford biologics, you can try mixing 2 or 3 of these agents. Biologics-wise, the best data is actually for infliximab. I don't know, that might be because it provides much more profound TNF blockade.
Thank you.
Can I go ahead with my presentation?
Yes, sir.
Okay. Good evening. I thank JB sir for this opportunity and feel privileged to share a case of a 23-year-old male from West Bengal who came to us with complaints of decreased vision in both the eyes. Are the slides visible?
No. Can you do the slide sharing? Can you share? Can you open the presentation?
Can the technical team help me with this?
Yes, we'll open it somewhere.
Yeah, thank you.
Yes, we can see the slide. Amitabh, you can go ahead.
Okay, so this was a 23-year-old male from West Bengal who came with complaints of decreased vision in both the eyes for the last 1 month. He was a known case of IgA nephropathy with end-stage renal disease, on dialysis, and he was awaiting a renal transplant. He was on antihypertensives at the time of presentation. He also gave a history of tuberculosis contact with his brother. On examination, his best corrected visual acuity was 6.9 and 6 in the right eye and 6.18 and 10 in the left eye, with a quiet anterior chamber and a normal intraocular pressure, whereas the posterior segment showed vitreitis in both the eyes with edematous discs. The retina revealed retinal hemorrhages with macular hard exudates in both the eyes with a placoid lesion in the left eye, and he had an exudative retinal detachment inferiorly in both the eyes. And this was his fundus picture at presentation, where we see disc edema in both the eyes with numerous flame-shaped hemorrhages and cotton wool spots and macular hard exudates. And the left eye, there was a placoid lesion, which I'll be coming to later, and a montage photograph showing the inferior exudative retinal detachment. And this is the placoid lesion which was seen in the left eye, which looked deep retinal. We did an ultrasound B scan, which showed shifting fluid confirming an exudative retinal detachment. And an OCT at this point of time revealed intraretinal cystic spaces with neurosensory detachment in both the eyes. So with this clinical picture, we thought of a malignant hypertensive retinopathy, but his blood pressure was normal. and Ffa was contraindicated because of his impaired renal functions. But because of the vitritis in both the eyes, a placoid lesion in the left eye, a history of TB contact, and regular renal dialysis, we did keep a possibility of an infectious etiology as well. So with this in mind, we went ahead with the vitreous biopsy, and the sample was sent for a PCR for the viruses and Mycobacterium tuberculosis. The patient was also referred for various other blood tests. And to our surprise, he tested positive for HSV2, whereas he was negative for Mycobacterium tuberculosis. So in consultation with a nephrologist, we started him on tablet valaciclovir 500 milligram once a day, and he was also put on a tapering dose of tablet prednisolone. We topped it up with intravitreal ganciclovir, and at 1 month, his vision improved to 6, 9, and 8 with quiet eyes. The placoid lesion regressed, the retinal hemorrhages disappeared, and the exudative retinal detachment resolved. An OCT at this point of time revealed the resolution of cystoid macular edema in both the eyes, but we did see some amount of subfoveal SRF in both the eyes. A follow-up at 6 months, his vision remained stable at 6, 9, and 6, and at this point of time, we saw some retinal hemorrhages and macular hard exudates in the right eye, whereas the left eye, the placoid lesion had resolved, and there were just a few hard exudates, and an OCT scan revealed resolution of the SRF as well. And this is at 9 months, when his best corrected visual acuity was 6, 7.5, and 6 in both the eyes, with just a few hard exudates in the right eye. So this is what we started with, and this is how far we have come, the photograph down below. We don't know what holds for him for future. Thank you for a patient hearing.
So thank you, sir. I would like to invite Dr. Sudarshan Sridharan, Senior Consultant in Uvea from Shankar Nethralaya, Chennai, for the discussion. Over to you, sir.
Thanks, Neetu. The Seshadri, the slide, that's a slide, the last slide is the discussion slide of the same presentation.
Okay.
So basically, Amitabh has totally covered quite a lot of things. Like we are not very sure probably what is the actual thing. The clinical picture is of a malignant hypertension. And as he said, in an advanced renal impairment patient with IgA nephropathy, we probably think of all these ocular features due to hypertensive retinopathy changes. But his BP consistently has been normal, and he's been on regular antihypertensives. So there has not been a hypertensive spike. So if at all we are looking at the history of contact with TB, but tests and PCR for MTB are negative. When you look at those lesions, they are probably outer retinal or maybe choroidal eye, we don't know. But it's looking mostly outer retinal, probably no CT. So when TB was one thing, obviously in India we keep suspecting, and then all these tests were negative for it. The placoid lesions, other infective etiologies were ruled out. Are we dealing with the non-necrotizing retinopathy was one of the suspicions. And when in doubt, we always keep thinking that intraocular specimen evaluation is the way to go when blood ancillary investigations are not helpful otherwise. So, and to his surprise, probably they found positivity for HSV2, and retrospectively we start thinking probably it worked well. But the question remains whether it worked because of the steroids or because of the antivirals. Although antivirals dose is very less considering the patient's age and otherwise. The dose is lesser because of the nephropathy and changes. So the next slide. Or probably, I don't know, if you put everything together, then we are probably dealing with the case of a retinopathy with IgA nephropathy in an atypical retinitis, which is proven by PCR positivity from vitreous. And when you look at the response later on, then you find maybe we are in the right track. I request other audience, other panelists for their opinion about this.
So that the dramatic response to antiviral therapy with intravitreal ganciclovir is inconsistent with a kind of a viral etiology, and of course is supported by the PCR of the intraocular specimen.
One thing we probably could have done is maybe the vitreous sample, we could have done the viral copies, which would have given
RT-PCR.
us, yeah. So which would have given us whether they were viable genomes to rule out false positive PCRs from the vitreous. But Otherwise, other infective agents were negative.
How long was the antivirals given in this case, Amita?
Yeah, we continued him on antivirals for around 2 months.
And that too only 500 milligrams
Right.
once a day.
Yeah, that's the
And
maximum dose within which the nephrologist agreed to.
And how many injections did we give? At
Just
what
one.
interval?
Just one.
And that too in both eyes?
Both eyes, yes.
So only one injection and 500 milligrams once for 2 months.
That's right.
Yeah. Which is quite unusual, actually. It looks like a subtherapeutic dose, but considering the renal parameters, and we cannot give a full therapeutic dose, it's quite surprising that the patient has responded very well, actually. Very fortunate for the patient.
Fortunate for us as well.
Yeah, I think. And there's no recurrence. Like, we need to really follow it up. Like, was it really an HSV2 positivity in the vitreous, which is again so unusual.
Right.
But do we really think that it was false positive? Like, probably a real-time PCR can give us a better idea on that.
Right.
Copy number it could have shown.
Yeah, copy number.
False positive is from the samples is more unlikely than false negative.
Yes, sir.
Someone's asking whether it is post-fever retinitis and immunocompromised.
Yes, sir.
Yeah, again, that's the same thing. How do we prove that? Or we investigate for all the viruses and rickettsies and those things to get a negative answer.
There is another question raised by Dr. J. What is the indication to do vitreous tap in uveitis?
Darshan?
I guess that's a general question overall, not particularly for this case, I guess. So when you're suspecting, when clinically you're not able to differentiate between an infective or non-infective, and when you're suspecting a particular type of infection with atypical presentations, immunocompromised, then we probably try to do vitreous tap in our situation. When you want to rule out an endophthalmitis from an inflammatory panuveitis.
And also a patient who's not responding to steroids, and usually we in tertiary care, we always see the patient has been treated for a long time with steroids in different forms. And we know that they're not responding. I guess then in those cases, vitreous tap is the next way to go to get an answer for our conditions.
So I think we can wind up this case. We'll move on to the last case. I would like to invite Dr. Gassel, who's doing the Uvea fellowship from Shankar Nethralaya, Chennai. Gassel, you can take over.
Are my slides visible, ma'am?
Yes.
Yes, it is visible.
Good evening, everyone. Having heard about so many clinical challenges, let's have a look at another clinical challenge dealt on a Delhi real-world scenario. It's a case of a 50-year-old male who came to us with complaints of diminution of vision associated with pain, redness, and lid swelling in the right eye since 4 months. He also gave a history of fall of vegetative matter to the right eye while working in the field 10 days prior to the onset of the ocular symptoms. He has been thoroughly investigated locally, and the laboratory showed negative MONTOX, interferon gamma release assay, ANCA, and HIV reports with a normal chest X-ray and complete blood counts. However, CT orbit was suggestive of dacroadenitis with surrounding inflammation. So the patient was treated with injection gentamicin and cefotaxime for 5 days, followed by oral ciprofloxacin 500 mg twice daily for 10 days. However, he was also treated with systemic as well as topical prednisolone for 4 continuous months. On presentation to us, the best corrected visual acuity was 660 in the right eye and 6/6 in the left eye. However, here it is important to note the keratometric value, which showed high astigmatic error in the right eye. So as we can see here, there is a diffuse boggy scleral swelling with scleral congestion superiorly, scleral thinning with uveal show, however, fully conjunctivalized from 1 o'clock to 4 o'clock. There is congestion of superficial and deep episcleral vessels. Cornea is clear, anterior chamber was quiet. To note here is the appearance of the pupil being directed, eccentric and peaked towards the thinned out portion of the sclera. Intraocular pressure and fundus were within normal limits. So suspecting a diagnosis of infectious scleritis, scleral biopsy was planned and the patient was started with oral ciprofloxacin 500 mg twice daily. On day 3, we noticed an increase in the scleral swelling with a pustular appearance. So, and at the same time, the smear showed gram-positive filamentous bacteria suggestive of nocardia. Awaiting the culture report, the patient was started on fortified amikacin and moxifloxacin at 1 hourly interval with ciprofloxacin eye ointment thrice daily, along with oral Bactrim DS and indomethacin with pantoprazole. However, modified acid-fast stain with 1% sulfuric acid also showed gram-positive filamentous bacteria suggestive of nocardia, and the direct culture on blood agar as well as the subculture showed chalky, white, dry, rough raised colonies, very characteristic of nocardia. As again, the DNA sequencing revealed the species to be Nocardia amamniensis. However, on day 7, we noticed hypopion and keratic precipitates and endothelial deposits in a linear fashion, and the pus point was punctured thrice during the course. However, retina was on and vitreous cavity was clear. Suspecting endophthalmitis, he was administered with intravenous amikacin and cefuroxime twice daily dose along with other treatment. Scleral debridement with antibiotic wash of amikacin was also given to the patient. On day 10, point, hypopion, and the keratic precipitates all looked resolving. On day 14, however, small exudate localized at 1 o'clock position superiorly in the anterior chamber was noticed. However, the patient was symptomatically better and the inflammation was resolving. So the same treatment was continued. On 1 month of follow-up, we can see here there was no pus point, no hypopion, no keratic precipitates. Only mild inflammation was still persisting, for which topical betnesol in tapering doses along with homatropin was added to the current regimen. And the patient was followed up after 2 months and with a complete resolution of the inflammation, keratic precipitates, hypopion and the pus points. However, the vision remained at 660 with a high astigmatic error. Having learned about the case, let's dig deeper. Over to you, ma'am. Thank you.
Thank you, Dr. Desel. I would like to invite Dr. Mamta Agarwal, Senior Consultant at Uvea, Shankar Nethralaya, Chennai, for the discussion.
Thanks, Neetu. Thanks, Ghazal, for presenting the whole case. Let's go through a little more in this details about how do we see these cases, nocardia scleritis. So what we know from scleritis is infectious scleritis, which is just 5 to 10% of all the cases of scleritis, which we all see. And it has been reported that nocardia is the second most common cause in India, being a tropical area, more humid. And they say that nocardia choroidis is more complex. However, in our case, we found a new species, amamiensis, which is still not reported in literature. The most common predisposing factors in these cases are trauma with organic matter and of course surgery. But then trauma being organic matter is the most common in patients with nocardia scleritis. And they're usually presenting as multifocal nodular or ulcerated lesions. The main differential in these cases is fungus or atypical mycobacteria. And how do we diagnose these cases? Easiest and fastest. It's a smear, which is gram stain or Zn stain. Culture may take a little longer, but then polymerase chain reaction and DNA sequencing gives us the specific genome. And histopathology, of course, is most helpful in patients we are not able to diagnose. Treatment is both medical and surgical. What medical is amikacin, which is the most important drug which responds beautifully in all the cases, but we can also add on fluoroquinolones and cephalosporins. And surgical de-roofing, debridement, and antibiotic wash has an additive factor which debulks the infectivity and also enhances the penetration. This is a beautiful article, which is a review article on all the cases of nocardia published so far in the literature. And the authors have analyzed that there were 43 cases where predominantly males were involved. And the duration of symptoms, it can be 14 to 70 days. Most important is that the diagnosis was nodular multifocal scleral abscesses, which was seen in 32% of all the cases published so far, and trauma was seen in 50% of the eyes. And again, we emphasize that gram staining is the most common test, which shows thin branching and beaded filamentous rods, the easiest way to diagnose these cases. And the most preferred antibiotic was amikacin and oral Bactrim, which we actually gave in our patient too. The surgical debridement was done in 75% of cases on all the cases published, and a good resolution was seen in nearly 83% eyes, though the treatment is long and tedious and it needs repeat debridement. So this was a recent case report which we published in Ocular Immunology, and this patient, as you see in the first picture, he was diagnosed to have immune-related scleritis, treated with steroids, subsequently diagnosis of TB scleritis. Again, patient worsened on steroids and ATT. A scleral biopsy was done and it proved nocardia. And this is a good response again to amikacin and oral Bactrim. So how do we distinguish these patients? Infectious and non-infectious scleritis. We all know that either it's a direct invasion of pathogens by bacteria, fungus, virus, or protozoan, or it can be an immune-related phenomenon to the microbes present in sclera, and it is most commonly seen post-surgery or post-trauma. It may spread from the adjacent structures too. But what do we see in these immune-related scleritis? They are basically related to the collagen disorders like rheumatoid arthritis, SLE, and few others. The clinical signs in the infectious scleritis, we do see purulent exudates, ulcers, abscesses, and hypopyon. But then they may also present with a subtle finding, which is just a nodule and which may be easily missed. And they may mimic the non-infectious scleritis, what we see as diffuse nodular lesions, overlying scleral edema. And the treatment investigations, again, as we discussed, it is based on microbiological investigations. But in the non-infectious scleritis, we need a detailed workup for rheumatoid arthritis and other connective tissue disorders. And treatment is entirely different. What we know is antimicrobials and surgical debridement in infectious scleritis. And the role of steroids is controversial, and rather contraindicated in fungus, atypical mycobacteria, and nocardia. What we do in non-infectious scleritis is topical and systemic steroids with immunosuppressive agents, which may end up with biologic agents also in patients with rheumatoid arthritis or granulomatosis with polyangiitis. So these are few of the cases I would like to share. The case first on the left side is the nocardia nodule. Below this, in another patient with a fungus, what we see is their intense scleral congestion, but there is a yellow nodule, which we see is a quite specific finding for these patients with infective scleritis. But interestingly, this is a patient which was published by Dr. Biswas group, and this was a syphilis nodule, which was again treated only with steroids, but the patient responded beautifully with antisyphilitic treatment. And then on this right side, we see different pictures, which are again fungal scleritis. And this is an interesting case. What we see here is a viral scleritis. How do we see these patients? If you see the cornea, there is a subtle nebulomacular opacity there, which can give us a clue that it can be a viral keratouveitis with scleritis. And again, in the last picture, there is a pus-pointing nodule, which I want to highlight, which is quite simple to see that it is just an ulcerated nodule, and it's quite straightforward that this is infective scleritis. So in conclusion, I would like to say that infectious scleritis should be suspected. Patients with a history of trauma, surgery, and chronic use of steroids in any form, patient not responding to the treatment, the diagnosis should be high on infectious scleritis. And etiology, we know it can be exogenous or endogenous. It's often elusive, and because the organisms lie deep within the sclera. Biopsy and scraping can help us to diagnose. Antimicrobial therapy should be started as soon as possible, and scleral debridement of the infected tissue is indeed helpful in these cases. Thank you so much. I'm open to questions.
Do you need to, sorry, this is one question. Do you need to add topical or oral steroid along with the antimicrobial?
Not in cases with nocardia, fungus, and atypical mycobacteria. In bacterial scleritis, when we are sure that we have given enough antimicrobials, let's say for a month, then probably we may add low-dose oral steroids, which takes care of the inflammatory part of the scleritis.
Ma'am, I have a question. How long to continue oral Bactrim in this case?
In this case, we continued for 3 months. They say you may have to continue for a few months, 2 to 4 months. Like my other cases, there was a patient where I had to continue for more than 4 months because they come with a recurrence and you're never so sure because the bug is deep within the sclera. And what the literature says, they can even present in patients post-pterygium surgery a few years later with these infections. So I think they need close follow-up. But I guess 2 to 4 months is like definitely these, especially nocardia.
And will you plan a scleral graft for this patient? And if so, when you can?
So scleral graft, again, it's like you're covering the infective part. So unless the wall is really melted and you need a support to prevent the ocular structures, we need to do. But otherwise, it's like we just monitor them and start on these systemic antibiotics. But yes, of course, if it is melted to that extent that to prevent the globe this thing collapse, we have to do it. So it's case-to-case basis.
And there has been few queries from the audience side. How to do a scleral scraping? Why it is done in this case, which looks like an impending staphyloma?
So scleral scraping, so to get a tissue sample, either it's a scraping or it's a biopsy. When it's a nodular lesion or when it's an ulcerated lesion. It's very easy. If it's an ulcerated lesion, you can just do like a corneal scraping, put the topicals, explain to the patient, put a speculum, and just a gentle scraping over the ulcerated area will clinch the diagnosis because if it's an ulcerated area, you are expecting very easy sample from smear and culture. But in this case, initially when we saw it was a nodule under the conjunctiva, you're not seeing any pus point, so you cannot puncture anything. In that case, you have to take it to the OR, give under peribulbar anesthesia, and you have to de-roof it. So you have to do a peritomy over the lesion and then look around. But you have to be very careful because the underlying sclera sometimes can be really thin. So you have to just mark your small area, the area which you feel that it is most pointing towards the abscess, and just open it up carefully and give some samples for smear and also take a tissue sample for histopathology. And then leave it bare. You don't need to cover it with conjunctiva or anything.
Another question by Ranju. How common is endophthalmitis in a case of infectious scleritis?
So again, it's like you cannot relate the two things like how common is it? It depends. If it's post-trauma, you can have endophthalmitis. So how far the injury is. If it's a penetrating injury, you can expect endophthalmitis. But if it's just a superficial trauma, let's say there are patients who come as farmers and they say, I had a dust fall while working in the field. I had a rice flour going in my eye. So we don't really see that they end up with endophthalmitis. So it depends upon the amount of injury. But yes, post-surgery patients, you can have endophthalmitis. So then in that case, you will have a corneal involvement, you will have a sclera and the intraocular, which are pretty challenging cases. And sometimes we do end up having evisceration or enucleation in these eyes.
One last question by Sachin Shetty. Any tips how to do scleral debridement avoiding perforation?
I think, yeah, that's the same thing what I said. It's a very tricky thing, and you need to really assess how deep is your sclera and how thin is your sclera. So if you see that there is scleral thinning and there's a bluish hue, you know that there's a very thin area. So again, I showed my clinical pictures, like if it's a small pus pointing, you can just take your 26 gauge needle and puncture it, and you can just take the thing. It definitely needs some experience, but if you feel you're not comfortable in the slit lamp, then better to do it in the theater under more control and patient is more relaxed, and we can give a peribulbar anesthesia because sometimes it's pretty painful for the patient. So if you're a beginner, I would say, and then you could just take it to your infected theater and do a peribulbar block, put a speculum, and then take the sample in a more controlled fashion.
Okay.
So I have anything for, is Dr. Ramanan around? Yes.
Yeah, I am.
Hi, I just have a question. Like, I'm seeing a couple of patients on rheumatoid arthritis treatment, and now they're developing these kind of infections. So how common is that in your practice? Because they are on biologics and they're heavily immunosuppressed. Like recently we have a challenging case and we don't know intraocular, what is it? and patient has been treated in a year with 4 biologics?
That's a very difficult question. Dr. Sudarshan just asked me that on a message. I don't have an answer because we don't see infective scleritis like you do. And here, as you know, most people who work in farms wear protective eye gear. So this sort of accidents or vegetative matter and biological material in the eye is incredibly uncommon. So we only see inflammatory scleritis. Infection would be extremely uncommon.
And post biologics also, you haven't seen much. Probably it's
Would be unusual on biologics to get scleritis. So that would be more likely, you'd have to be highly suspicious that it's infective. Presents a challenge.
So in that case, you would say immunosuppression is not a main reason to get infected scleritis. Would you like to say that?
I wouldn't, because I haven't got experience. I'd be very cautious of what I say, because I really am. I'm more ignorant on this area.
Yeah, because we have a patient which is also published, and that was an HIV with a candida. So it is just that it was an endogenous thing. We don't expect it if patient doesn't give a history of any trauma or whatever. So we suppose that because he was heavily immunosuppressed, HIV status, the etiology being.
I'd bow to your expertise here. I don't think we have this expertise here. So I'd be asking you if I had problems.
Itu?
So I think with this, we have come to the end of the session. It was a very lively and informative session, and this was made possible by our expert panelists. I thank each one of them. Thanks for being with us this evening. I would also like to thank all our young fellows who had presented the cases. I would request Dr. JB sir to deliver the vote of thanks.
No, actually, I've got a presentations. Is that one? So this is, I thought that we have done enough challenging cases, thought-provoking cases. I thought that is a little bit of research which you are doing. I should talk about it. Is the clinical research in our department. We are the largest uveitis clinic probably in the world. We have got 11 people in a well-equipped laboratory and ancillary investigation support. Next. So today, from the Ramanan's talk and Professor Ramanan's talk and others, we said that today we need research to find out that what should be the answer for the questions which we are having challenging day-to-day challenge in the clinic, infectious, what is non-infectious, etc. So today's facts are probably the yesterday's research. Next. So Shankara Nethralaya with this mind has not only that patient care education is involved in the research also. Next. So we have done clinical research and which resulted in that PubMed index publications of 264, 3 books and 2 monographs. Next. So we have completed 11 clinical research projects. Some of them have come into the results trial and drugs now available. So question is that why we need clinical trials in uveitis? Because we do not have, particularly as Professor Ramanan told beginning itself, we still do not have an ideal treatment for the uveitis. Many of the treatment has got several complications and limitations. Proof of concept is needed. Efficacy and safety of the new therapeutic treatment and strategy has to be decided, like JAK inhibitor or tocilizumab, etc. Which we need to do that, find out their safety and efficacy. Next. So clinical results done elsewhere may not be applicable to our patients, so needs multicentric trials to involve ourselves in that. Next. So some of the projects which are done, which has resulted in the clinical product, one is the fluocinolone acetonide implant, which was tried in our patients in randomized trial. Efficacy and safety of dexamethasone applicator system in the posterior segment of the eye, which has resulted in the Ojudex. And we are now doing an investigational study of Shankara Nethralaya tubercular uveitis study. Next. So As I mentioned, the Retisart and Ojudex are the two treatment modality which has been studied by us with now available as FDA approved drug. Next. So this is a fluorescent aspirate device. We did 30 patients with chronic non-infectious uveitis. All eyes had reduction of inflammation, but cataract and glaucoma are the important complications which have faced. Next. This is one of the case of pan-uveitis on pre-treatment and post-treatment 8 weeks after. You can see that marked resolution of inflammation with vitreous is completely disappeared. Next. Ojudex is other implant, dexamethasone implant, which we have tried over here with a randomized trial. And next. This is the small pellet which is given inside the vitreous cavity, biodegradable. Next. So this has resulted in that publications with dexamethasone intravitreal implant in non-infectious intermediate or posterior uveitis as a modality of treatment, which has been FDA approved later on. Next. So this is a case of a cystoid macular edema 9 times. Foveal thickness was 619 micron. And you can see that one single Ojudex implant, next, has resulted in the foveal contour maintenance, and the thickness has reduced from 600 to 171. Next. And this is the Ojudex implant which you are all using in uveitis, intermediate uveitis or non-infectious posterior uveitis. Next. This is a biodegradable, it slowly diffuses. Next. So we have done a clinical study in intermediate uveitis with Ojudex implant, and efficacy has been found to be quite good with good safety profile. Next. Currently, we are doing 2 trials. One is the MERIT trial study. Next. Another is the Lumina. MERIT trial study involves next macular edema ranibizumab versus intravitreal anti-inflammatory therapy. This is a multicentric uveitis steroid treatment trial. Next. Dr. Sudha Ganesh is our deputy director, is the principal investigator, and this is funded by the National Eye Institute. Next. And this is a 3-arm intravitreal dexamethasone, intravitreal methotrexate, intravitreal ranibizumab, which has been used in the intravitreal dosage for other reason. And here we are using for macular edema, and the duration of the therapy is 6 months. Next. And the patient should be an adult, 18 years age or older, inactive or minimally active non-infectious anterior, intermediate, posterior pan-uveitis can be taken, and they should have macular edema, which can be detected by OCT, and baseline FFA would be done, and base corrected visual acuity should be 5/200 or better, and intraocular pressure would be less than, should not be less than 5 or more than 21. Next. There are several exclusion criteria was there, that infection, glaucoma, central cell retinopathy, non-infectious scleritis, epiretinal membrane, silicone oil or other Ojudex implant within the 12 weeks, systemic medications patient is taking, systemic IMT, use of oral corticosteroids, other systemic carbonic anhydrase inhibitor. Next. Next. We are doing another study called Lumina study. Next. It's also a phase 3 trial, multi-center sham-controlled randomized double-mask study, as the efficacy of intravitreal sirolimus. Myself is the principal investigator. Next. Next. And this is a locally delivered mTOR inhibitor, inhibits the T cell activations, proliferations, and differentiation, increases the regulatory T lymphocytes. There is a pre-injections, and you can see the drug depositions is slowly diffuses, and forms deposits in the slow diffusion over 2 months. Next. This has come from the preclinical to the clinical studies. Next. So today we are in the phase 3 currently enrolling. It has gone through the phase 3 is the Sakura 1 and Sakura pharmacokinetic study. And now is the Lumina study is going on, and indications next. Next is that, so there is the intravitreal injection of sirolimus is given in 440 microgram, 6 months double mask period to confirm the efficacy and safety, and 6 months open label period to evaluate the long-term efficacy of this drug and safety. Next. So primary objective is to evaluate the efficacy of intravitreal injection of 440 microgram of D109 every 2 months. Is the primary efficacy endpoint is vitreous edge should be 0 at the month of 3. And the secondary objective is to find out the vitreous haze clearing off and corticosteroid tapering success. And at the end of the 3 months, as well as at the end of the month 5. Next. There are 3 arms. One is the test arm, where you give the intravitreal injection of sirolimus 440 microgram. Control arm is the SAM procedure, and dummy arm is given in the undisclosed 440 to 44 to 880 microgram. Every 2 months is given, 1 month, 2 months, and 4 months. Next. Next. So the review of the main inclusion criteria is the vitreous haze. Best corrected visual acuity should be more than 75 letters. Methotrexate azathioprine, if they are used, should be dose remains stable. Systemic corticosteroids, if are permitted, as the dose remains stable between 15 milligram per day to 40 milligram per day for at least 7 days prior to the randomization. Next. Main exclusion criteria is, of course, that there should not be predominantly anterior uveitis, should be posterior or intermediate uveitis, should not have intravitreal anti-VEGF injection or intravitreal or posterior subtenon steroid. Use of difluprednate is also excluded. Next. So this summary of this research which you have done and which you are doing, I thought that I will bring it to you. Probably is that next. Today's therapy is that probably the future of therapy is that today's research will bring tomorrow's treatment. The way that it has come to that implant or biologics. So we need to probably, along with our clinics, taking the clinical challenges, we need to really look for that better treatment options, and research is the only way to go for that. Next. Thank you very much. At this, we have a very wonderful, almost 2.5 hour session. I like to thank profusely and with our heartfelt thanks to Professor A.V. Ramanan, Dr. Vivi Kaushik, and our panelists, Dr. Sudha Ganesh, Dr. Amla George, Dr. Sudarshan, Dr. Mamta Agarwal, Dr. Suchitra Pradeep, Dr. Binita, and wonderful moderation by Dr. Sharana Abraham, Arshi Ahmed, and Nitu Latif, and our presenter, that Richa, Divya, Advaita, Gajal, Amitabh Kumar, and had got a nice presentation as food for thought, everybody. And I like to thank the audience for participation, asking questions, and that multimedia of Mohan and Mohan and the Malati, Mrs. Malati, who has helped us in organizing this meeting. Thank you, everybody, and have a good night. As it was a wonderful experience to share our cases and listening to Professor A.V. Ramanan. And we like to thank everybody for the presentations and participation. Thank you very much. Bye.
Thank you very much.
Thank you all.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Kaushik.
Thank you very much. Thank you.
Thank you. Thank you, Hallmarks, for the support.
Thank you, sir. Thank you
Thank
for the
you.
opportunity.
Thank you.